Start the recording. Good evening, everyone. We welcome you all to Ortho TV. It gives me great pleasure in welcoming everyone for the first West Zone Indian Orthopaedic Association online academic event. To introduce today's program and the speakers, I hand over to the coordinator of this event, Dr. Abhijit Kale.
Thank you, Dr. Neeraj Bijlani.
Please put on your video.
On the behalf of the West Zone Indian Orthopedic Association, I welcome you all to the first CME. This is the first CME of the trauma series, and the topic for today's CME is injuries around the knee. We have got legendary speakers, and before we move on to the scientific session, there will be a brief words from the office bearers. May I call upon Dr. Ajit Shinde, the president of the West Zone Indian Orthopedic Association, to say a few words. Over to you, Dr. Shinde, sir.
Thank you, Abhijit. Respected Iowa President, Dr. Professor Ramesh Sen, sir. Vice President, Dr. Ram Chadda. Secretary, Dr. Naveen Thakkar. And my team members of West Zone. Vice President, Dr. Vikas Jain. Dr. Sadanand Bandekar. And my teacher, Professor Dr. D.D. Tanna sir, President and Secretary of Maharashtra and Gujrat Orthopaedic Association, Dr. Vasudev Gadegone and Dr. Narayan Karne, Dr. Govind Purohit and Dr. Gamlesh Devmurari. Also, POS President, Dr. Rajesh Gandhi and Dr. Neeraj Bijlani, and all the respected faculty members. Welcome to the first ever webinar of West Zone of Iowa. It has been an inspiring journey since the inception of West Zone of Iowa. As all of us are well aware that Iowa already had fully functional Central and South Zone named as Oasis since many years, and North Zone and East Zone forming their association. It was the need of the time we should also come together and form strong association at national level. The formation of West Zone was ratified in Iowa AGM 2021 Goa, involving eminent states of Maharashtra, Gujrat, and Goa. Since then, West Zone has started taking active participation in various academic events. We have participated in Gujrat Orthopaedic Association Conference, GoaCon in Silvassa, Vairog in Mumbai, and even in North Zone Orthopaedic Association Conference. With tremendous talent that we have in our upcoming generation, our aim is to provide a grand platform to our members to present their academic aptitude and to strengthen our presentation at national level. Today, we will be discussing common problems and management of injuries around knee joint, which I think is a very important topic, as any missed or mal-altered knee injury, maltreated knee injury can lead to troublesome disabilities in one's life. I think Dr. Abhijit and Dr. Ashish has really chosen the topic well to begin our webinar series. We have an excellent panel to discuss the issue with the stalwarts, Professor Dr. Tanna and Dr. Chandak as a moderator. I am sure this is going to be interesting discussion by the case presenters, Dr. Jignesh Pandya, Dr. Naveen Thakkar, Dr. Paras Motwani, Dr. Dhaval Desai sir, Dr. Swapnil Kotadia. I am really looking forward to many such thought-provoking discussion in future with our bright and esteemed faculty. I thank Bombay Orthopaedic Society for their valuable support. United we stand strong. Thank you, Dr. Abhijit and Dr. Ashish, for well-organized and ensuring that everybody is on board in today's webinar. And thank you to Team Ortho TV for their collaboration. Thank you, everyone, and my all the best wishes for today's webinar. Thank you. Now,
For your encouraging words. So for the encouraging words, just have the president of the Indian Orthopaedic Association of Jain, traveling, he is not in a position to deliver his address. Next, may I call upon Vikas Jain, the Vice President of the Indian Orthopaedic Association, to give orientation. Over to Dr. Vikas Jain.
Hello.
Right.
Naveen bhai,
Vikas bhai, please.
am I supposed to speak because I could not got those words clearly?
No issue. You can speak, and then Dr. Govind bhai can speak, and Dr. Gadegone can speak, and Dr. Rajesh Gandhi, one by one, we can speak. Give the introduction. Yeah.
Okay.
Because you
So,
can start, Vikas bhai. Yeah.
Yeah. So, congratulations to the West Zone, and as a Vice President, I endorse all the points, all the wishes that has been given by the President of West Zone, Dr. Shinde. And I personally believe that West Zone with Gujrat, Maharashtra, and Goa, along with Bombay Orthopaedic Society, is really a torchbearer and will take orthopedics to new heights. We have been doing great orthopedic work, and with this CME of Trauma Series 1, we are beginning the new chapter. Already we have had offline events in GoaCon, in Vairok, and in North Zone. But let us begin again with more academic activities, and I wish you all the best. Thank you so much, all the panelists here.
Thank you, Dr. Vikas Jain, sir, the Vice President of the West Zone, for his encouraging words. May I now next call upon Dr. Govind Purohit, the President of Gujrat Orthopaedic Association, which is the state chapter, to organize this CME, to say a few words. Over to you, Dr. Purohit, sir.
Unmute yourself, Dr. Purohit. Unmute. Yes, please go ahead. Dr. Purohit, Govind bhai.
Hello.
Yes, please go ahead. Say a few words about it. Yeah. Your voice is not coming. Hello.
Can you hear me?
Yes. Now we are listening. Please.
Hello.
Yes, we are listening now. You.
Yeah, we can hear you, sir.
Yeah.
See, I am in the remote place in Rajasthan actually, but still I would like to enjoy to attend this webinar along with the dignitaries and the West Zone Ioa, and I wish you all for the presentation, and we proceed at a higher and higher educational level with this number of webinars, and at the end we will take some of the messages from our senior teachers, professors in the connection with the injuries around the knee joint. And also we know the main problems of the knee injuries are stiffness, non-union. These are the two common complications, and I have one or two interesting cases for discussion at the last. If time permits, I would be pleased to discuss these cases as far as the management is concerned. Again, thank you all for inviting me in this webinar, and wish you all good luck for the good academic event. Thank you.
Thank you. Thank you.
Thank you, Dr. Purohit, sir, for the gentle words. Next, may I call upon Dr. Gadegone, sir, the President of Maharashtra Orthopaedic Association, to say a few words. Over to you.
Abhijit, for inviting me for this wonderful webinar of West Zone, which is comprising Maharashtra Orthopaedic Association, Gujrat Orthopaedic Association, Goa Orthopaedic Association. We are having a number of webinar and physical meeting in Maharashtra, all the corners, and our aim is to sharpen surgical rationally and improve patient outcome. And therefore, we are organizing Young Surgeon Forum, Veteran Surgeon Forum, and educational activity at par excellence in Maharashtra. And I think this is West Zone in combination with Gujrat and Goa under the leadership of Ajit Shinde sir. We will go forward and we will achieve a new height, and it will be most recognized Western zone in the history of Indian Orthopaedic Association. So welcome all dignitaries and presenter, and thank you for giving me a time to say a few words on this prestigious, on the occasion of this prestigious webinar. Thank you very much.
Thank you, Professor Dr. Gadegone, sir, for your encouraging words. Next, may I call upon Dr. Rajesh Gandhi, the President of Bombay Orthopedic Society, to say a few words.
Good evening, everybody. It is wonderful to see everybody on a Sunday evening together for a academic feast. And I'm very sure with under guidance of Dr. Shinde and Dr. Naveen Thakkar, Dr. Govind Purohit ji, Dr. Gadegone sir, and all other dignitaries, the West Zone IOA will reach newer heights. And we wish you best of luck. Let us start with the proceedings and start the academic feast. Thank you very much for inviting me as well. Thanks.
Thank you, Gandhi, sir. Next, may I call upon the Secretary of the West Zone, Dr. Naveen Thakkar, to say a few words, and after that, he will start the scientific proceedings with his talk on distal femur fracture, the Mechanico biological saga. Over to you, Dr. Thakkar, sir.
Yes. Thank you, Dr. Abhijit. And we are thankful to all the faculty for accepting the invitation of contributing in this subject. And this is the first webinar of the West Zone trauma series. This will go on academically because West Zone is very strong in the academics. And we are thankful to all the faculty. So we'll start the program. And on the starting the program, my appeal or a small request as a being also a secretary of the Indian Orthopaedic Association, those who are not the members from the Maharashtra, Gujarat, those who are not members or from any state, please become the member of Indian Orthopaedic Association. Just because Indian Orthopaedic Association to young orthopedic surgeons is providing multiple opportunities of fellowships, Ioa mentorships. So for that, you have to become a IOM member. At least you have to apply this year, and you will get all the benefits like member except voting powers. So my appeal is to become a member and ask your friends, those who are members, to become a member. And my second appeal is our annual event is at Amritsar this time. So please register and contribute the orthopedic science. Send your abstract. 30th June is the last date of accepting the abstract. And you can showcase your innovation, your work by presenting there in our premier this event, IOCON 2022 at Amritsar. So we'll be starting now academic session. I am sharing the screen. Let us start with the first thing where I was asked to present. It's coming, it's not coming.
We can see your screen, sir.
Yes, yes, you can see, but it is stopped somewhere. Yeah, now it is coming again. Is it full screen now?
Yeah, now it is full screen.
Now it is full screen. So the subject is invisible medial instability in the distal femur fracture, the saga of biomechanics. I will try to make somewhat interactive so that we can learn together. The first thing which we see regularly in the distal femur is the fracture is fixed in such a fashion, and gradually it goes into the varus. This is the common feature. It gets united, but as you see here, it goes into the varus. So this is the common problem of medial combination, and then the fracture gets united many times. Either the plate breaks or it gets in the malunion. So this is the problem. So can anybody say length of the plate is a problem here, Dr. Chandak sir? Do you think that length of the plate is a problem here, short plate?
Yeah. I would have gone for a plate longer than this, somewhere around the 13 to 14 or 12 to 13 holes for this fracture particularly.
Okay, so the concept is to have a longer plate. Anybody wants to add anything? Anybody has an issue with this plate or any other issue with this fixation?
Naveen, by the principle applied is wrong, I think, over here.
Right. Right. Where it is wrong, sir?
I mean, you should have had a flexible fixation. I mean,
flexible fixation. So for a flexible fixation, you require a longer plate, and that
No.
longer plate must have.
No, you don't want unwanted screws over there.
Unwanted screws are not required, and the screws should be, even in the long plate, should be in the alternate fashion, not in the continuous fashion.
Yeah.
That is the concept which we are learning till we are learning, right? So the audience or the majority of the faculty says that here the culprit is the short plate, and the method, the way it was fixed, that is the problem, right, sir? So now I am presenting the second one. Double by. Here surgeon has put a long plate. Is it okay, sir? Can you see the X-ray? Double by.
Yeah, we can see the X-rays.
Yes.
Dolbai, what is your comment here? How the surgeon has done? He has left this part. He has fixed the distal block and alternate screws, very long plate as Dr. Chandak sir has said, of 12 hole, 13 hole. What do you think, sir? Chandak sir?
I think the reduction is also not right here.
Reduction is not right?
Yes. So, you see, the shaft is lateralized.
Staff is lateralized. Okay.
So even the length of plate could have been still better.
Still better. Okay.
And the screw near the fracture zone could have been avoided. Yes.
Here.
Yes.
What do you say here? Okay. Yes. It has to be avoided.
I think it is not could. It should.
It should.
Yeah.
Yeah. This screw should not be here.
It should not be here. Yes.
It should not be here. So this is making a working length less,
short,
and it makes it a stiff fixation.
Stiff fixation.
Right, sir. Right, sir. Right.
And blade is only 10 holes. This should be longer.
Still longer. Okay.
Yeah.
So,
sir, I get that Dr. Dhaval Desai sir wants to give his opinion. He has raised his hand, sir.
Okay. Okay.
नहीं वो last case का था हो गया.
Okay. So this case also same opinion.
Here now you see what is happening. It's a flexible fixation relatively than the previous case, but still it is. Anybody has any comment? And this is the final result. There is no breakage of the implant. It is united like this. The nature has.
Hello, Naveen bhai.
Yes. Yes. Go ahead. What do you want?
Naveen bhai.
Yes. Govind bhai, please go ahead.
Yeah, basically, this type of comminuted fracture, long fracture, this is the basic problem which leads to this type of problem irrespective of the type of fixation. We should add something medially. So only just like in the lower and the humerus, here the double pillar fixation is most important to stabilize it. We have now started doing not plate but 1 or 2 enders nail 4 mm medially to support the medial pillar, and it works very nicely also. So the audience may be of the different opinion. This is my opinion. Because of the communication, we cannot pass the screw through that, and the chances of fracture of the plate are also more in this type of cases.
Anybody wants to say anything, sir?
So what is the science of this medial ender, Govind bhai?
What is the
Medial
science?
pillar stabilization.
It is a possibility of possibilities.
Double pillar fixation.
So when you say pillar, where does it
The
hold in the
basic
medial
principle
fragment?
in this type of fracture.
Medial fragment, distal fragment में कहाँ पकड़ता है?
Yeah, definitely.
Where does it hold?
From medial condyle to femur, it holds very nicely.
Sir, it is intramedullary, free nail.
Just try once or twice and you will realize the situation.
Sir, it is not try, it needs evidence.
Yes, yes. It requires evidence, but there is a one possibility of one thinking, one hypothesis is there. It is running. We are also doing, but this is still a hypothesis. We do not have a series. We do
Actually,
not have
nail has no purchase on either end. Actually, nail has no purchase on either end. It is free. It is a cancellous bone distally, and you enter the nail, rotated and moved, so it is loose there. And it has no hold in the medullary canal. So it is just lying there, giving you salute.
It is just
Once you put the plate, the nails become tighter and tighter with the compression by the screw from the opposite side.
But
And
the
it controls
composite
everything.
brisket will solve the problem. We don't need a medial thing here, anything.
Okay, you know, don't need a medial thing, Doctor.
Medial incision
do you
will not
think
be
that
avoided for the plate.
do you think that there was no need of the medial plate here in this case, and if the long plate has been used, it would have gone
There was
very
need
well?
of the medial plate also in this type of cases.
Jignesh bhai.
Yes, sir. I believe
But
that
instead of medial,
proper bridge plate with a proper principles following and do maintain the proper ideology placement of the screws and length of the plate. This fracture will unite without any medial support.
So, can I comment?
Yeah, yes, yes. Please,
Yeah.
Chandak, sir.
So, is the first follow-up very important in all these cases? Even if done very nicely, at around 6 to 8 weeks, if you find that the medial column needs another stability, so double column stability, a medial plate added at early during the healing phase, is that what is you want to suggest?
Yes, it has to be observed. It has to be observed, and whenever it is needed, you have to investigate.
Naveen, if I can add.
Yes, sir.
Naveen,
Yes, sir. Yes, yes, sir.
I used to initially believe that nice 13-hole plate with only 3 screws proximally alternate in such a badly comminuted fracture is going to be enough. But nowadays I feel that if the fracture is so badly comminuted, even if you put in a 12, 13-hole plate with 1 screw here, with the other screw and the alternate screws and 3 screws there, without avoiding the screws near, still it is not a stable construct all the time.
You're right.
To me, I believe in a overkill.
Yes.
So
Yes,
if it is a
so, sir, I call it is an invisible medial instability, which we may not be knowing on table. We are not able to judge exactly on the table. Surgeon is not exactly able
no,
to.
I think here you can judge it with all this. Here with all these things which is there, so much of an instability which is there, and obviously this is the plate which is bent, which I feel is the Indian plate which is used.
Yes.
I would have definitely put in a nowadays. Earlier I talked about it that you need only the alternate screws 13, 14-hole plate, but nowadays I think I will not take a chance. I'll put another plate here.
Yes, yes, sir. The question is, the surgeon initially thought that probably he will not require the from the first X-ray, he thought that he will not require the medial fixation.
No, I think he believed in the theory part which has been touted by all the faculty.
Yes.
So Naveen bhai, so what is wrong here? Why did this bend? Tell us.
Yeah, it is bent because of the forces of the medial instability is continuous, and nature tried to get it collapsed.
So no. But Naveen bhai, so I think if you see in the zone of comminution, let's go back to the.
Yeah, it is here, sir.
So the two things are wrong. One is that the shaft is pulled laterally. Second is this screw nearest to the fracture has made this construct.
Anybody feels that shaft is pulled that much laterally?
Certainly, I think the cortical screws shift.
No. It's not there, sir. It is not that much laterally.
Probably there is a medial wall commission. The cortical fragment is moved out. That's why it looks like there is a lateralization.
But it's the axis is probably right, I think. What he has judged on table as the axis is almost right, sir. We do not have a full length X-ray, but you are right. There may be some.
Second is that first screw is in the zone of combination, and therefore you have a very short segment that makes it rigid, and that's why this is bent. Very simple as that. So you can't blame instability for a wrong principle of fixation, I think.
So was it stable? You think
no,
that
but
it was stable?
That's
fixation?
because you made it over rigid by putting that first screw inside the zone of combination. Now you only have a short working length. That makes this fixation probably not good enough flexible.
Short working length makes an implant concentration forces at one place only.
Right,
so all the concentration forces are at these 2-3 holes only. So that's why the plate is bent.
And do you know the case presented by Dr. Tanna sir, where it was a non-union? In spite of non-union, he put a bridge plate. I think it was Dr. Susrut case, and still it got a good union.
So the result obtained.
So I think compression and everything in the metaphysical region, it is not working probably. It is a stability. We are not able to judge the exact stability exactly in the same case. We do not know exactly the stress and strain pattern in a particular case. Every case it differs. And every case the amount of the stability and the amount of the instability differs. That is the issue, I think, sir.
Naveen bhai, do you have a pre-operative X-ray?
No, we are not having pre-operative X-ray. This is the only X-ray available with us. Okay, sir, we are going ahead, sir. Right? So now we are primed that we are discussing without it's a short plate, long plate, stability, instability. What are the issues here? So whether there was something wrong with the long plate? No. Now another case you say here, it's a very long plate. You can see here. The surgeon has fixed, he had put a graft also here, but it was an artificial graft, that artificial bone, and it has failed. So it's a red flag. We do not know exactly what is there. Either there was a short plate, long plate, even there are failures. Even with the long plates and done rightly, as Dr. Tanna sir has said, what we were learning and teaching, it's a continuous learning process. But it was failing also in spite of all the principles are taken care of. So again that case, but as Dr. Govind Purohit has said, and we have also tried this method in a minimally comminuted in a crumpled mold in the elderly people. We have tried this method of fixing with the flexible nails. We just support with the flexible nails on the medial side. And it gives a 3-point fixation with the multiple flexible nails, and it passes nearby the screws. So automatically there it gives some friction and some stability. As you see in this case, very small incision on the medial side, and there is a support. There is a medial buttress here. It gives a buttress in this area, and then it is a flexible at multiple contact points and multi-plane, multi-surface, small points of fixation, which is required exactly that amount of the instability is covered by these flexible nails. That's why it works. We do not know exactly the indication where to use, where not to use, how much it is effective, how much, because we do not have the evidence. But it works.
You have done here, you have done the leg screws, you have done all that, and so you are giving the credit to the Anders nail, I think
Yeah.
probably you're very generous to the Anders nail.
Yes, yes, yes. It is very generous. You're right, sir. Fixation was done with the interfragmentary and then
Screw.
and then thought that some instability is there. That was the mind, so that was added.
But if you want to prove that the Anders has worked, is in those cases.
I'm just describing the possibility of possibilities. Here it is. Here it is. Here not. He is not the. Here it is not the right case.
Yeah, it is misinformation. It's a misinformation.
Just a piece of information, debatable information, sir.
Agreed.
It's a debatable information, but we have to look for such series where we can prove that whether it is possible or not. But these possibilities are gradually described in some part of our trauma surgeons. And this was the function, right, sir? The theory what is a possibility is probably there is a continuous cyclic loading biomechanically on the medial side. And when these flexible nails are there, probably they are giving some micro motion and some stability and callus formation on the medial side, which is not possible with the lock plate, which we observed that the callus is not occurring on the opposite side. That was the issue area of the locking plates. When the locking plates, we thought that it's a great innovation for the distal femur. Still, it is a good innovation for the distal femur, but problems are coming, and now literature is giving that biomechanically something is wrong somewhere, and we are getting 32% of the non-union in the distal femur with the locking plates. But we have to find out the reason. We do not have the cases, the group of the cases which are made together are whether rightly done or wrongly done. There is a mix of the cases in the literature. So many times we do not get exactly the message whether surgeon has done in a right way or wrong way. That's why there is a non-union.
Naveen bhai, may I interfere?
Yes, sir.
Sir, when you have used on lateral side the locking plate, how can that the ender nails will provide a flexible construct axially? It is impossible. There will be no movements on the medial side. If at all movements has to occur, that will happen, plate will become loose and it will fail. So therefore, only the medial condyle from the intact medial condyle or supracondylar region, if it is there, then and then your ender nail will work. Otherwise, in a fragmented condyle, how it will work? It will become loose and come out.
It doesn't work in the fragmented. Here,
yes,
the medial condyle is intact.
Intact. Therefore, it has worked.
That's why it is giving 3-point contact fixation.
Yes, and the callus formation, it is because of the there is already
controversies.
Yes. So right, I don't believe that there is a cyclical loading on medial side by this thing.
No, this is just a possibility.
Okay, thank you.
This is just a possibility, sir. I am not proving. Okay. Just the hypothesis that why it has worked in some cases and why in certain cases it is not working. And we do not have the evidence, but we are thinking in that line of there is a possibility. Science is a realm of possibilities only, sir. So now we'll take this case.
Naveen, we have similar case enders with plate. If allowed, I can share the slide of that X-ray.
Later on, sir. Once let it get
same
in your
case I have done with the enders nail medially. With the plate, when we are fixing the screw, the nail gets tighter and tighter. Even if the medial condyle is comminuted, it will act as a buttress nail, and it will not loosen out. It will not come out also. If it is single nail, it won't come back out. This is the beauty of this fixation we have seen in 3-4 cases.
Okay, so we need a more number of cases to get the power to the evidence, because we do not have a power with
exactly
our hypothesis. We do not
if
have
I
a
can
power.
suggest, Naveen, if I can suggest, people have been talking about the Anders nail as same way as here doctor is talking. As you know, Kulkarnis are the ones who started, but still they have not been able to give a sufficient number saying that it has worked in those badly comminuted fractures. It is all, it is a hit and a miss situation. So I don't think that's the one which we can really advocate. But, very rightly as Dr. Purohit mentioned, if he has a series of cases, we'll be highly obliged for us if he can really show us and teach us.
Right. Sir.
But 1 or 2 cases probably means nothing much.
He said that 3 cases, so that's why I said about the power, sir. We do not have a power to prove it, so that's why we have to make together cases and power, and we have to show the failures of that method also. Then we can come to know the.
This is one of
the
concepts which we are developing.
Oh yes.
So it could work in 68% cases, which are otherwise also going to unite.
Yes, right.
right. Possible. That is also a possibility. Yeah, that is also.
That's too small a percentage to really succeed in a patient.
Right.
I think any treatment which is below 95% is not adequate.
Right, sir.
Chandak, here.
Chandak, sir. Yes.
Yeah.
Here, this case is presented to you. The previous surgeon has operated, and 16 weeks has gone, and now it has come to you. How will you proceed, sir?
So
highly comminuted fracture, yeah.
So 3 things I would like to know. Is he holding on well? Is he functionally fine? Is there any pain? Answer
no,
to
I
all
think Chandak, if all those things are still there, at the moment the distal end of the femur is angulated, the last screw is not parallel. You have a chance to really correct all that, correct the whole axis of the femur, remove everything, give the femur and the knee joint a good alignment, and then add up a next plate, another medial plate.
Absolutely.
That is the ideal situation, right, sir?
But many times these patients during follow-up heal, they may not be ready for conversion to new construct. And I believe this fracture, because of this zone of comminution and the amount of, though there are so many things to be desired, it's not a long plate, etc. But I believe seeing this fracture at 16 weeks, it is holding on. This may go for good union. The valgus is there, agreed, sir?
Yes, valgus is the issue, sir. Yeah.
If he is not willing for another operation now, if it unites, he is never going to be willing. Then he is going to be stuck with the medial osteoarthritis very quickly.
Yes, sir.
And the varus deformity.
Yes, sir.
So probably when there is a chance,
at least
we go down and correct it.
Right.
But sir, here it is reverse. It is in the valgus. It is not in the varus, sir.
Yeah, valgus.
It is the valgus.
But still, as you can see, the medial compartment is complete.
Yes. That may be because he is around 58. So it may be previously
Anyway, proceed. What has happened?
Yes.
Plate टूटा के नहीं, plate टूटना मांगता है.
नहीं, sir. I want to ask Dr. Jignesh Pandya, whether you will what will you do, sir? You will revise to the long plate here, Jignesh bhai, double bhai.
Sir, I will use a combination implant here because intra-articular portion is united. So I will correct the deformity, pass intramedullary nail, and then plate and derotation bone grafting.
So you will put a nail and plate.
Nail plate and bone graft.
So you will remove this plate. You will put a nail. And
I will correct the deformity. I will correct tilting of the condyle.
Right. That has to be corrected, right?
Because these screws are not parallel, and the whole medial condyle is totally vacant, empty.
So you feel that there is an instability. There was an instability in spite of this fixation. At 16 weeks, it is not uniting. There is an instability. Is there? Do you feel that it's an unstable situation even after the fixation?
Yeah, it's just waiting for the plate to break.
It is waiting for the plate to break.
There is a good evidence that in a distal femur, 4 months is not a good time to judge.
Yes.
The plate can break after 7-8 months also.
Right, sir. Here, surgeon did the fibula graft and not change that plate and just added up this plate, small plate, 2 screws below and 2 or 3 screws above, and a bone graft. What do you think, Jignesh bhai, now? How it will go further?
Fracture may unite, but he will have deformity.
Fracture may unite, but it may have a deformity. Right, sir. Anybody has any other opinion, sir? So, it has went on and it got united very well with this function and this alignment. This is the alignment of the limb here. You can see it.
Sir, we have to make HK axis X-ray. We can't judge on this. We have to take HK axis X-ray.
Full X-ray we have to take. You're right.
Yeah, that is then we can comment on
right.
alignment is okay or not.
So again, the case which I had shown you, the previous case, long plate surgeon has used non-structural bone graft. Do you think the plate is long here? Very good, long. What was the issue here?
Plate is already breaking here.
Yeah, it has started breaking. Yes, it has started.
And again, everybody should absolutely understand the distal end, the first screw has to be parallel to the joint line.
Yes.
If it is not parallel, I think there is something wrong in the axis.
Yes, there is
and probably the plate is too distal to me.
Yeah, I think it has gone. I think after X-ray, immediate post-op X-ray is not there because there was a litigation. And I removed this plate. There was a cold welding here, this titanium plate. It was very difficult to remove, but it was removed like this. And then a long plate, fibula, and the small medial plate. Whatever the instability was that, this axis was corrected, tried to be corrected, and it is just like this here.
I presume you have drawn the fibula arbitrarily. It is not, and you must have put it on the medial side rather than the lateral.
No, this is just to show the color in color.
That's what I am saying.
Fibula is here, sir. Fibula is here.
Yeah, exactly.
Fibula is here, but if I put here, this fibula will not.
Yeah, I understand. I understand.
That's why just I put a fibula here. The photograph was there, so I put it here. So full fibula strut, medial structural graft. The problem was the surgeon had put a non-structural graft. If you want to put here, you have to put a structural graft. Here it was a overkill, fibula and the plate, but still it was required because there was too much of the void here, and there was a litigation already, and this was a Desai patient, Rabari patient. The problem was there. This is 9 or 10 months after, as you said, after this plate broke after 9 months. So this is going in the follow-up. What will happen? Jignesh bhai. This is in the follow-up after 6 weeks of the primary surgery. That was immediate post-op with the stitches.
It's already consolidating.
Yeah.
Fracture, but you see, if you see the AP view, it is showing the notch view of the femur. So femur is in a flexion.
Yeah, slightly flexion. Absolutely right.
Because you can see the posterior cortex.
Yes, we can see.
Because AP view is showing the notch view of the femur. So it is in flexion.
It is in the slight flexion. Right, you are right.
Flexion or extension?
Naveen bhai, when this fixation was revised, both sides were operated. Only one side they did.
No. It was revised. It was that plate was broken, sir. You were not
Okay.
there.
No, I was a little away. So that's what Jignesh is saying, that the alignment is not good.
Alignment is not good here. You feel
The coronal plane.
in the coronal plane.
Yes.
You may be right, but there was too much of combination here.
It is recurvatum.
Yes.
But Naveen bhai, જો આટલા બધા screw નાખ્યા તો correction તો આવી જ થાય ને એમ.
Right. You're right. But every time, whatever you see in the X-ray and what you see in the function may not be slightly different. You're right, absolutely. We are describing the X-ray.
So I think, Naveen bhai, it's very difficult to predict union in this case at the end of the fibulas. If you see the lateral, go the other X-ray again.
Yeah.
So this zone will take a while to consolidate. I mean, one would not be very
that
sure.
That is the message that don't be in a hurry. When you have done a repeated surgery and you have put in such a long long span, it takes time to unite. You have to be very much cool and calm, wait and watch, and explain the patient that yes, union X-ray will come. It will take time. It at least takes 6 months. Tanna sir, am I
longer?
Right?
Sir, which approach do you take? Do you take 2 approach or a single approach?
Single approach.
That's why, because your all plates are anteromedial and not medial.
Yes. Single approach, sir.
Because if somebody takes medial approach, then he can put definitely very nice buttress medial plate.
Yeah,
I don't think it makes a difference. Does it make a difference? Jignesh?
I don't think it makes it. It gives definitely posteromedial better support.
I have used an anterior plate when there was a bigger amount of bone available distally, so that you don't have to open up medially at all.
Right.
You need you need a double fixation in 2 axes.
Yes.
Orthogonal.
Orthogonal. Multiplane fixation, right, sir?
Exactly.
So now it is gradually it is showing the union. As you see progress from here, this X-ray was disappointing, but now gradually.
How many months was this X-ray? First X-ray?
This was 3 months. This is 6 months. This is 9 months, sir.
And 8, 9, 10 months is the ideal. It is the standard thing.
Right. So this is the incision. You can see that the previous incision and the now incision, and this is the previous incision of Mepo plate, and this is the modified swashbuckler, and this is the fibula grafting, and you can see here the function.
Naveen bhai, you and your patient is lucky to get this type of movement. After this, I don't think you will get a more than 90 degree of movement.
Yeah, you're right, sir. So what was the wrong there? Whether it's a short plate, long plate, or else, it is an invisible medial instability, which I try to coin it a word like that. That on table we are not able to understand the. Still there are medial instability even after fixing the lateral plate, and we.
Naveen, Naveen, if I can comment.
Yes, sir.
Why you say invisible?
Invisible.
To some people it is invisible.
Yes.
But to quite a lot of people it is completely visible, no?
Yes, sir. It is invisible. Those cases are remaining. For them, it is invisible, sir.
Exactly.
It is not for all.
I am sure it was completely visible for you at any time.
Yes, sir. These are all secondary cases that came from other surgeons. Yes, sir. So now how far you can go medially, that Dr. Jignesh Bhai was asking. There is a beautiful paper here, and as you said, you can go medially here up to here. I have put a plate medially up to here, and this is a beautiful paper. He has divided the joint of the femur into these 6 joints. This is the paper by this gentleman, where he has said it is very safe to go up to here. And they have studied with this angiography and everything. They have studied how far you can go medially. So medially going is not a problem. Previously we were thinking that to go medially it's difficult, but once you dissect very well, it is a minimally invasive. Mepo doesn't mean that you have the small holes. Minimally invasive inside is also good, even if there is a long incision on the outside. So minimally invasive, this is also minimally invasive. But the length and the plane of the medial plate is also very much important, where you put the plate. So it is not just the plate which can help you. There is one case which I am presenting here, but it's very controversial. That patient was not ready for a graft, fibula, anything. So we tried to put an intramedullary medial buttress with a thin plate. And we try to intermingle these screws with the holes in that plate. This was serving as a medial buttress, and this is a lost implant. It's very debatable and controversial. Only one case I have done. There is some literature somewhere. Then I went back and I
Endostyle plate. Endostyle plate.
Lost implant, yeah. And this was the function. It was also a non-union, painful non-union with the limb, and now it has a good function. So whatever we have learned for the rigidity and the micromotion, we know theoretically loading, number of screws, screw distance, working length, bone plate distance, the size of the gap, and after the fracture callus, the stress and strain pattern is changing, working length, strain, plate failure. These are all theory we have learned, the plate screw density, but many times this doesn't work in each and every case. Many times we see that principles what we have learned, the plate and bone model construct biomechanically, the distance of the plate from the bone here, as you increase the distance, the stability decreases. So many variables are working together, and probably these people have tried also this possible solution of far cortical locking of the flexible screw to get the flexibility and good callus on the medial side. And this is a beautiful video from AAOS, and where orthopedic knowledge, where they have shown it theoretically that it is a movement, and they have done a experiment on the sheep where there is a medial callus is there, and they have shown the movement on the bone with that flexible screw. If you see the video, there is a movement that they want to show us. And they have shown some cases, but still it has not come in the limelight practically for every orthopedic surgeon. Probably it is experimental and it has not worked fully. That's why it is not in the market. So surgeon has to balance the on table, reduce the risk of the plate failure, optimum interfragmentary movement biomechanically, what the stress and strain should be there on table. So now they are coming, since these people are coming with the new plate, where the thickness of plate is different here. There is a slot here already. And there are now limited holes here to put the screws. So surgeon has no confusion. Only all 4 proximal screws has to be occupied. No controversy. This screw, alternate screw, this screw should not be there. Near to fracture should not be there. There is no hole near the fracture. Here only these are the screws available. These are the only holes available. And there is a slot here. And the thickness of the plate is also variable. So it gives a flexibility. Automatically here is a transverse slot. Still it is in the experimental stage, and these are the studies which I could found in the literature, where it is a 5 mm locking and it is a biphasic. So it is a flexible, and then once the callus starts, it becomes more and more rigid. So that is the theory here. But what should be the future? Future should be a smart implants, where implant itself can measure the stress and strain in individual case. What will happen on the cyclic load? And till that time, as Dr. Chandak sir has said, we have to see at 6 weeks, 8 weeks and intervene early. That is our own smart observation on the X-ray, what stress and strain pattern is going. As Dr. Chandak sir has said, that the X-ray will speak what the stress and strain is going in that particular case, and whether you require a medial stability further or a graft or fibula or something like that. So
if I can intervene, Naveen.
Yes.
Intervene early.
Yes.
It will be the second operation.
Yes, second.
In Bombay, second operation is another 2.5 lakhs. In a Chandrapur, second operation is still 40, 50,000, 60,000, 80,000, and another stress to the patient and the surgeon.
Yes.
Why?
Why? It is better always to have a little
overkill on day one.
And have a medium.
I think as when I was talking to you, so beautifully you mentioned to me, can there be an underkill in a safety of a prime minister?
No, it cannot be.
When Kashmir said 370 was abolished, how many soldiers were there? So the same thing is here. I would probably give a practical position. I wouldn't say my opinion, practical position. If there is a bad comminution, do all what the books mention. Put another plate medially. It doesn't have to be absolutely medially. It can go medially onto the distally and can come a little anteriorly. That is the safest position.
Yes, sir. So it is a little bit of the instability which has to be taken care of on table on the first day, on the first instance itself.
Absolutely.
That is the message, sir.
Sir, I want to get it my clear. I am confused now. So you
you are notorious for confusing everybody else. So if we can confuse you, I think
what is a flexible fixation? And you say the invisible instability. In a flexible fixation, we want that there should be invisible instability so that it throws some callus.
Right.
Then and others say, Dr. Sir, actually sir has already cleared it that he wants absolute stability at the fracture side to get for union. There is no confusion from his side. I am confused because of your lecture that you say on this that must be a flexible fixation. So flexible fixation wants some instability, relative stability means some instability, invisible, at the fracture site to throw a callus formation. So now I am confused. What is a invisible instability, relative instability, and flexible fixation?
So it is a absolute stability. It is not absolute stability, but it is absolute stability. It allows some micro motion. So we do not know exactly we do not know exactly each and every patient, each and every case requires a different stress and strain pattern.
But suppose if it is absolute stability, that means invisible instability is there.
What we describe invisible stability, where you are not fixed the medial side, there is the invisible instability.
No, but there are so many evidences also, single or double plate combination in a comminuted fracture of the supracondylar region. It's a very controversial issue. There are n numbers of paper that a single plate works, either double plate works. So the double plate is also overkill, that there is chances of stiffness and infection are much more. So you have to dissect it very properly. The Hunter's canal. Suppose साला Hunter canal बराबर नहीं तो artery तोड़ देगा वो, तो उसमें then you will have a problem. So there are so many issues. So
sir, इतना medial जाने की जरूरत नहीं है तन्ना sir. Do we need to go to the Hunter's canal?
If I can opine, micro motion, which is very important for a comminuted tibia and humerus, and it is enough that micro motion, few screws on the either side. But in a femur, the muscles are so very strong that only the lateral plate, which I had been through it earlier, only the lateral plate with 3-4 screws proximally alternate, till the muscles in the femur are so powerful that if it is badly comminuted like this with the gap in between, is still not enough. So if I am operating a case like this now, I'll put a lateral plate and anterior medial plate. It is medially onto the side and then slowly comes around anteriorly so that you're not bothered about the femoral artery.
Yes.
Anyway, it's controversial very rightly, as Dr. Gadi has mentioned.
Yes, it is a controversy. That's why I
think we proceed further now. There is no
yes. So from the nature, we have to learn how to get stable, still flexible. So thank you very much. So now we can go for the next talk, sir.
Thank you, Dr. Naveen Thakkar, sir, for that enlightening talk. Next, may I call upon Dr.
We must thank Naveen Thakkar for confusing the issue which has already been confused by everybody.
Yes, sir.
Yeah, but the take home from that talk, as you rightly mentioned, sir, that whenever there is a combination on medial side, what is required is a dual fixation, either 2 plates or a nail with a plate. A nail, something like a supracondylar nail, along with a lateral plate whenever one sees a medial combination.
No, I think it is we genuinely we cannot really give that as a solution. We are only giving the opinions because there is an opinion on either side.
Yes.
Okay.
Very well taken, sir. Your point is, yeah. So we move over to the next interesting topic in the injury around the knee, and that is the Hoffa's fracture. And we have with us an eminent orthopedic surgeon from Nagpur who needs no introduction, Dr. R.M. Chandak, sir, to speak on this. Over to you, sir.
Sir, unmute yourself. Unmute. सर अनम्यूट किया आप, अनम्यूट नहीं आप, म्यूट हुए सर. सर आप म्यूट है. चांडक सर आप म्यूट है. Unmute कीजिए सर.
So I'll be speaking on.
Now you have to share again.
Yeah.
Okay, sir.
So you are able to see now?
Yeah.
Okay.
Make it a full screen, sir. Yeah. Make it cancel it. Yeah.
Just a minute.
Yeah. No issue.
Yeah. Thank you very much, Abhijit. And here in Hoffa's fracture, it is good that we will be needing only absolute stability. So Hoffa's fracture we all know is a coronal fracture of the posterior femoral condyle, and which condyle usually splits coronally. Most commonly it involves the lateral. Lateral medial also can get affected, and bicondylar Hoffa is also known, as can be seen on this picture. The classification by Lettner gave type 1, type 2, and type 3, and recently Weber, Bagaria classified them into 4 types, which gives a practical solution to the fixation modality. The diagnosis, usually all of us would get X-rays. CT scan is mandatory for any intra-articular fracture, and MRI is also useful in certain situations where we feel about the ligamentous injury. Oblique views are particularly useful for delineating which condyle has got affected, and oblique view has a relevance in intraoperative imaging under a CIAM imaging intensifier. CT clears the real doubt, which type of fracture it is, where is the condyle broken, how much is the amount of comminution, and importantly, whether there is a lateral condylar or the medial condylar blowout, which may require a buttress fixation. And 3D reconstruction is also useful in where there is a cross displacement of fragment, which gives us the precise location of the fragment. And MRI tells us how little or small fragment even is there. The amount of soft tissue injury can help us, and the ligamentous injury as well. So this was a patient of posterior condyle where we have to go posteriorly and then put posterior anterior screws in this case. The principles of treatment are well enunciated: anatomical reduction, absolute stability, giving us a chance to have early movement, which actually heals with a good cartilage, and we respect soft tissues. The 3 important things emphasized are: there should be no step off, no depressions remaining, no gaps. So if it is there, gaps are there, we will fill up with the bone graft. Provide a stable internal fixation, which would withstand the early mobilization, so that you start a very early range of motion. And in some cases, provide a buttress fixation to the posterior aspect of condyle, so that the condyle doesn't move posteriorly and we can have a good buttress fixation. The fixation modalities most commonly utilized in a stable variety is interfragmentary screw from anterior to posterior or posterior to anterior, depending on the fragment location. Commonly used are 3.5 mm cortical. We can use 4 mm cortical, and when the fragment are large enough and we can take a good purchase, 6.5 mm cancellous with the required amount of thread length. Buttress plate for metaphyseal extension and for blowouts. The screw fixations can be multiple. Usually minimum 2 screws are mandatory, which should be perpendicular to the fracture, anterior to posterior or posterior to anterior. So from posterior to anterior, passing screw is a bit difficult. You need to position your patient in a lateral position, make your window available, put a guide wire, and then on that you can drill your screw. The mechanical stability of 6.5, 3.5 and 4 is almost good enough. The approach I would usually like in a routine lateral Hoffa is a semi-lateral position. We have to dissect out a bit more so that we can display the fracture zone quite easily. The medial approach is also required for a medial Hoffa or a lateral Hoffa. You have to delineate the fracture line, cut the TFL, and display the fracture geometry very nicely. If it is anteriorly placed or in the middle segment, it is easier. But if it is going posteriorly, you need to have 2 or 3 knee blocks to give you flexion, and the reduction then is done in extension. So the steps of surgery are very simple. Inspect the joint, visualize the fracture line, clean it. I would usually use a lot of dura elevators of curved nature to palpate the fracture posteriorly, anatomically reduce, hold, and then initiate drilling at the patellofemoral junction perpendicular to the fracture. When the reduction gets difficult, there are certain tips and tricks which help us out to get the fracture visualization better. Bone spreaders. So you can use a Hunterman retractor, or you can use a different type of retractors to just distract the joint line so that you can visualize more posteriorly, see the comminution, see the defect. Once that is done, then a reduction clamp and a joystick technique to reduce the fracture is utilized. There are various clamps which be quite useful here. Get the reduction well. You may need joystick from anterior to posterior fragment. Many times you also need to push the posterior fragment anteriorly and push it distally if it is displacing posteriorly. So you can use a K-wire, on that a cannulated punch, so that you push the fragment forward. So distraction helps no posterior. Like in this case, if you want to go, if you are not visualizing well, then we would like to use a distraction. In difficult reduction, we can get a proximal hold. If we have a beak of the posterior condyle, it is very nice to fix this so that we get an exact reduction like is done in this case posteriorly. To get reduction finer, proximal buttressing helps in many situations, especially in delayed case if the patient is coming, proximal reduction, holding that beak and then going back to the interarticular portion and fixing with the interarticular pins, and then add interfragmentary screws like was done in this case. So the screws passing perpendicular to the fracture zone, buttressing proximally so that we provide an early mobilization. Though countersink is recommended by AO, but what I find in our Indian population, the amount of bone stock, many times countersink I would not be using. So either use a headless compression screw or even 3.5 4 mm screw, which usually countersink by themselves. And we need to use the exact measurement of screw. So measurement, you can usually using a depth gauge is not possible here as it goes posteriorly. So I will use the K-wire, just let them go up to the subchondral region and measure from the K-wire available in the difference, so that we use exact size screw. Confirm on oblique x-rays that your sizing is absolutely proper. So here oblique views give you a condyle which is being operated so that there is no confusion in which side you are operating, and then calculate the size of the screw exactly. I also keep certain screws available which have less than 16 mm thread. So this is a 12 mm and 14 mm threads are available so that you create a compression across the fracture gap. A long screw may hurt the patient, and as in this case, my own case, this long screw remained and this got bent during the follow-up, though he had a good range of motion, but this was not the precise way. At times, we may need a posterior anterior screw, especially if the posterior condyle is very small, then we may need a stability with a posterior anterior screw. In comminution, when there is a lot of comminution anteriorly placed, you may use a small plate and on that 2 screws so that the washers, the plate itself works as a small washer. In grossly displaced fractures, we require the skills and extensile exposure. Like in this case, it was very difficult to reduce this whole posterior condyle. So this was fractured from this point, as we could see in the CT scan. This was really difficult, and getting that fragment back into position. And after getting it back, since there was no anterior good hold available, so we had to use combination of multiple plates. And in such cases, I feel a classical excellent implant is still not available. On table, I'll keep reconstruction plates of all sizes and shapes available, including a recon locking plate, so that we can provide adequate stability. And many times Kirschner wires are also very useful, because very small fragments, you need to have all those array of K wires, including 0.8 mm also, so that very small comminution can also be taken care of. And this case had a good fixation. As you can see in the lateral view, we had an excellent contour of the condyle in a difficult, completely displaced Hoffa. Buttress plate on a posterior order, lateral border also can help you buttress these fragments. So most of these Hoffas have a fracture line running from this point, and the fracture line comes to the distal part. So semitubular 1/3 flimsy plate itself, and when you buttress this onto the femur, though this going back is a bit more dissection, but then that provides the best buttress. And what I have found is this patient mobilized very well in the post-op phase, as they hardly experience any pain, and they do really very well. So that buttressing helps a lot, as you can see onto the X-ray. The standard distal femur locking plate is of no use for any distal Hoffa, because this doesn't hold anywhere onto the medial, or even in the bicondylar it doesn't work. What you would need is a plate, and I would thank Naveen for this drawing he drawn on a WhatsApp group. When the fracture becomes very complex in the distal and femur, there is a lot of combination, the blowout of lateral femur condyle. So here only the anterior posterior screws would not work. Here you would need definitely a plate substitution onto the lateral wall so that it is well molded onto the lateral wall and we have adequate stability. Looking at certain case examples. So this was a patient who was operated at another orthopedic facility, had an interfragmentary screw and 2 Herbert screw fixation. Though it looked initially quite okay to the primary surgeon, but as we can see here, this was not stabilized. And as we would expect, this patient developed a displacement during the follow-up. And that was corrected by a buttress small plate applied posteriorly in this zone so that that could be taken care of. However, these surgeries become difficult as the time passes and the knee becomes stiffer. So that was revised with a buttress plate, corrected and emphasized. This disasters of 2 screw only and no reduction.
Chandak sir,
Yeah, please go ahead.
You go previous slide.
Yeah.
Such a fracture, if you on which position you take, because first you start when you give a lateral approach.
Yes.
And it is in the supine position, I suppose, or lateral position.
Semi-lateral position. The best position I feel is semi-lateral because going to this angle to drill, you require a long drill sleeve. So the edge is delineated by a cautery dissection. You go to the posterior lateral border of the femur, then take a long sleeve. That is mandatory because otherwise the soft tissues get entangled. So take a long sleeve. These sleeves are of for drilling, for K-wire, and for even passing the screw. And then go posterior anterior. So it may not be dead posterior anterior. It is holding from posterior cortex to the anterior cortex bit medially. And then that the zone, the apex is neutralized. As we neutralize in the proximal tibia posteriorly. So apex neutralization helps a lot in such patient. And you have a good chance to do apex neutralization. And this zone is easily available. You are not going... Yeah,
no, I'm not against that. That is a very good technique. But if you shift the position to prone position, is it not will be easier? And then again go for lateral position.
Can be done, but I find posterior or the semi-lateral position is good enough because the AP imaging in Siam, AP and lateral, that becomes very useful when it is a semi-lateral position. However, you can go posterior also. But then again, you will have to have posterior first and then go anteriorly and from lateral side because most of this zone, you want to see this zone also. From posterior, you won't be able to see this zone. So posterior part, you will be able to see only this. And I had already committed myself with a lateral approach for the Hoffa. So in that case, I had to do this. So this case also, like you can see, a previous incision was there. He also was operated at another orthopedic facility, but the intra-articular reduction was not. And typically, this patient have a block and initially they have a block and then they become stiff. So any experience for managing such patient? Anything, Gadegone sir, you would like and appreciate and tell us?
It is only actually intra-articular incongruency and the arthropibrosis is the cause of stiffness in this type of a fractures.
Right.
So
your approach for such would be open reduction, and then how do you get better range of motion? Because many times stiffness is a great issue when in a repeat surgery. Any opinion?
Actually, we have to explain to the patient that you are not going to get a good range of movement, but articular reconstruction is possible with this method. That's all.
Yeah. Thank you so much. So this patient required a graft and recreating the zone of that fracture, removing the implants, and then providing fixation. Some bicondylar fractures, the bicondylar Hoffa is not that rare. We do find such patients with bicondylar Hoffas, which requires exact anatomical delineation and then fixation of the bicondylar by both providing the anterior posterior stability and a lateral stability by laterally fixed plate. This case is from Dr. Negi, and he provided a good fixation laterally and the Hoffa's fracture with Herbert screw. So you need a combination of management, not only the Herbert screw, not only the anterior posterior Hoffa screw, but you also need a lateral pillar stabilization. And especially when there is a large piece, it is quite comfortable to fix these fractures laterally. These are certain difficult cases where there is a lot of comminution in the posterior condyle, the lateral wall is blown up, so only anterior-posterior screw would not give any stability. And in such patient, you need to provide a good stable construct into the lateral wall. Nowadays, what I would do is take reconstruction locking plate, put them into 3 arrays. So one plate from this position to this position, second plate and third plate. And then we can mobilize these patients early. For medial Hoffas, you need a medial approach, and then you can see the whole medial condyle, reconstruct them. And this is a good technique where you put your finger, get the condyle into position and fill up all this void. Whatever void is there, you need to fill up. So keep a graft source available and then provide a fixation. A proximal humerus locking plate, not the Philos variety, is also a very useful plate medially, and it contours well and you can mold it also. And so this is the open reduction internal fixation with the anti-glide plate, and that worked well in this patient. A comminuted lateral Hoffa plus lateral condyle is one of the easier ones to do because the fixation is really good in these cases. There is clinical and experimental evidence that immobilization definitely results in joint stiffness. So all of our Hoffa's fracture should not be put into a sort of non-immobilized position. We must mobilize them early. Then only we are going to get a better range of motion in this patient. So should mobilize early. This was a patient who had a bilateral Hoffa and required fixation on medial side, on lateral side with the plate and the interfragmentary screws as well. However, this was the only movement achieved. We could not achieve beyond 90 degrees in spite of full physiotherapy. This was one unique case where a surgeon initially had done a ACL avulsion fracture orthoscopically. So this was orthoscopically put screws, and many times this screw, if it is proud, leads to some amount of flexion deformity. She had a lot of disuse, and one day she stumbled and fell down. So a difficult intra-articular screw removal and a bicondylar Hoffas was a very difficult situation, and profound disuse osteoporosis as well, which we managed with putting whatever constructs we could manage on that patient. So we did not go posteriorly because the anterior screw was to be removed. So from the parapatellar approach, we opened on both the sides and removed that. Friends, outcome after articular fracture depends on 3 important things: the inertial energy of trauma, residual malalignment, ligamentous instability, and the step-offs in articular cartilage. So avoid any step-off in articular cartilage. Then only we will have such an excellent result. So this was an X-ray after removal of the implant and everything, and had a useful function. In such difficult bicondylar Hoffas, we may use a parapatellar approach so that we can fix it very nicely in this situation. So take-home message would be, give anatomical reduction, absolute stability. You need an array of multiple types of fixation available. Choose depending on the complexity. Elevate all the depressed fragment, and that is a skill we have to learn. So get all the fragment back into position. 3 things which help us is dura elevator, cannulated punches, and small fragment bone set. Fix with interfrag screw, buttress with a laterally placed plate, and then early mobilization, and that would give us a desired result. Thank you very much, Abhijit, for this opportunity.
Yes. Thank you, sir, for a very elaborative yet a lucid talk. Any questions for Dr. Chandak, sir?
If I can ask you, Chandak, and
Yes, yes, sir.
In a neglected case, when you go down and you put a good articular reconstruction, and if still you have a stiffness, probably intraoperative, you have to do the arthrolysis, either arthroscopically or open, make the patella completely free from the patellofemoral. That is the one which gives to the marked stiffness.
Yes.
And all these cases, even later on, by a good arthroscopist, if he does an arthrolysis, releasing the patella from the femur, you can regain a fairly decent range of movement over the time. Obviously, you have to put it onto the painkiller, like a block and the CPM, and then you can really get them through to 70-80% of the range of movement.
Absolutely agreed, sir. And the case I showed did require orthoscopic follow-up at ortholysis at around 6 weeks post-fixation. Then only he got around 90 degrees of range of motion. Agreed, sir.
Second issue with the case you shown, many times it is very difficult to find out where was the apex when it is malunited. Recreate the fracture again, same in the same plane. It becomes difficult to in this
Yes.
Hoffa style.
So the
Many
things
times
which,
it
yeah,
goes so much so posterior, medial or posterolateral, then it becomes very difficult to get exactly the apex where it should be.
yes. So 2 or 3 things help there. Good retraction, a good quadri dissection, get dura elevator so that you go gradually dissect that apex and then go back. And then you need very small chisel and punches so that you can go into the zone, gradually go on doing your carpentry there and then get back the apex. It is difficult, it is not easy. And even after complete reconstruction, you feel something more is desired still to get back the complete reconstruction. Agreed, sir.
You feel that the map is not exactly matching.
Map is not exactly, yes,
भारत का
matching.
नक्शा अभी तक सही नहीं हुआ है, ऐसा
Yes,
लगता है।
yes, absolutely.
If in such cases, if you want to improve the visibility, which you need it in all cases, probably epicondylar or osteotomy, to have the medial or the lateral NCL or LCL ligament will give you a fairly decent view, which you can put it back with the screw and you will have no loss of any stability.
Agreed, sir.
So thank you, Dr. Chandak sir, for a wonderful
Dr.
talk.
Chandak.
We move over to the next.
Hello,
talk.
sir.
Hello, yes, sir. Please come out with your question.
Yeah, go ahead, sir.
Abhishek, at this
Hello.
stage, I think we'll go on till 10 o'clock. No, I think.
So we'll try to make it by 7:30 p.m., which is our deadline. Dr. Purohit, sir, do you want to ask a question? Okay.
Yeah, I would like to ask one question that how old Hoffa's fracture you have operated? Because recently we had experience of doing 15 days, 20 days old fracture, and it was difficult because such type of fractures initially on X-ray sometimes are missed. That is one thing. Second thing, these are part of the associated multiple injuries. So again, there is delay on the side of the fracture. So what are the precautions we should take? We had very difficult in, ultimately we could get it ultimately. So what is the maximum duration you have operated upon? How old fracture?
So I had operated around 6 to 7 months old fractures as well. However, you need a complete set of counseling with the patient, relative, good imaging, and then a theater planning that you need extensile approaches. And then you are able to get back with a consent for graft when needed. And then only we'll be able to do it. Yes, it is difficult, but doable. Over to Abhijit, I think we can move on.
But up to 6 weeks, I think you will not think twice.
Yes, up to 6 weeks will not be.
Because you will not think twice whether to go or no. You must go, and it's not difficult at all. It's a small amount of dissection to really correct it. I would say it is difficult, but it is not.
One thing I would like to ask, sir, another, if the fracture is neglected for 2, 3, 4, 5 years, then what will be the natural end result of this case? I would like to know from the faculties.
So this patient somehow get adjusted in walking. They may take a small cane. They have a typically khat awaz when they bend their knee, and they are able to manage. They have a limitation of restriction which they get used to. And on telling surgery at around 5 to 6 minutes that we will not be able to get back to original function, they would not yield to surgery, and surgery is futile. Ultimately, they would land up with orthoplasty over a couple of years or a decade.
President, I guess that answers your queries. We will now like to move on to the next talk, which is on non-union of the Patellar by none other than Dr. Tanna sir. Over to you, Tanna sir.
Yeah. 1 second. I come to the computer. You can see my slide.
Yes, sir.
sir. Yes, sir.
This is a very, very odd subject. Not many people have much experience. Not many reported cases of fracture patella. And I think it is something most interesting which I have been through. Now, if I can mention about this is the fracture patella and the anatomy of the extension mechanism. The patella, as we all know, helps in extending the knee joint directly, indirectly, as whatever it is now. Now here it is. This is the rectus, vastus medialis, vastus lateralis, tensor fasciae lata. This is the patella, and this is the ligamentum patelli. And these are the extensor expansions. These are the ones which are also equally important as the ligamentum patelli, which is attached to the tibia. This extensor expansion also comes, this is the retinaculi, and as you can see here, these are also torn in a fracture patella. As you know very well, this is the one patella where the patellar gives forces transmitted from femur to tibia, and it's only ligamentum patelli, but extension expansion also gives attachment to the quadriceps. So when there is a fracture of the patella, we suture the patella, but also onto the lateral and the medial side where the expansion is torn, we suture that also. That is a normal fracture patella surgery. Now, unless you can suture this properly, you will not be able to be fully satisfied with the result. Now, here it is, as you can see over here, patella, you have done the tension band wiring, and the expansion is also sutured. So surgery of the patella fixation involves suturing the expansion. So here is the patella, suture it, and then we suture the expansion, exactly as it is done here. Now this is the typical non-union patella. This is the way I treat my patella. I don't put a K wire. I reduce it, I put the clamp, and I put these two wires. One is the cerclage wire, and one is the anterior tension band wire. This is the way 8 months full function, and you can see fracture is not united till you get a good function. This is how I treat my patella, and this is how I treated a non-union. And fortunately, it wasn't a very old non-union, so it was not difficult to get the two segments together. This is a 4 months injury extension leg. This is, I'm talking about, you can see the date 24/18/9. So we're talking about something like 34, 35 years back. This is the typical patella. And this is the one which was treated like this. So now this patella, first and the foremost, 4 months old, they are separated out. So by releasing the patella, you get them together, get the tension band, and in order to see that the tension is not much on the suture line, you also involve the tibial tuberosity as a neutralizing force in this. I'll describe the surgery a little more in detail. Then I changed over to this because I felt that the patella here is a pieces which needs the protection, and hence the tibial tuberosity was included as a protection. Now the surgery, what involves is to freshen the edges of the patella. Now this is 3-4 months old patella. You got to freshen the edges. Generally, there is a hollow in the center in non-union. This increases while freshening the edges. So all when you freshen it, there is a hollow which comes there. Now, you with the fishtailing of the rectus, you will need a rectus femoris to be fishtailing there. And once you fishtail it, you will be able to get this patella down. So once you fishtail it, get the patella down. And once it comes down, now you do the suturing of the patella. But now the real treatment comes in. Expansion is healed in elongated position. In that situation, this expansion is healed in elongated position. Either cut the fibrous tissue and shorten the ends and resuture it in tight position. So just suturing is not there because these soft tissues are healed up in 3-4 months. You only suture the patella, but the extensor expansion is not only, it is not shortened, this will not function. So this is what I did it. I excised the part of the patella initially and then suture it back. So, or my choice is plicate the expansion by double breasting. This is much more easier. You make it area raw, plicate it by double breasting, make the sutures good so that the expansion is now made a continuous. So here it is. This is the expansion which has become bigger, lateral retinaculum. You take the stitches and you push them in and you stitch it up. So now this has been brought together, and this is the one now it comes back to the natural shortening or the natural length of the extensor expansion. So you suture the patella, you suture extension expansion on both sides, and this is how it is done. So put neutralizing suture patella to tibial tubercle in order to get the healing done. With tension so that 20-degree flexion is possible on the table without tearing up the sutures. 20 to 30 degrees flexion has to be there. It can't be in a 90 degrees because then you will not start the movement. And then gradually start the movement. Active rebinding is started in about 3 to 4 days once the pain is better. More than 90-degree knee is not allowed before 6 weeks. And in 6 weeks' time, patella tibial wire breaks. Patella tibial wire breaks in 6 to 8 weeks' time, and then the further knee flexion is achieved. And even this, as you can see, the patella suturing is also, it breaks down at times. This is 3 years, it has also break down. But you can see, surprisingly, even in spite of the fact non-union patella, you get a good range of movement and a good power in this area. Now, observation after 6 months. This is, though I think it is not this, is his picture at this time. I'll show you the picture afterwards. Observation after 6 months when the surgery was done, the expectation was patella will heal and active extension power will be regained. What was observed was neutralizing wires broke in about 8 weeks' time when the knee movements reached 90 degrees. And as the patient gained knee flexion, extension power also increased. To my horror, patella did not unite, but still knee extension power became 4+, giving no difficulty in daily activity. I renamed the surgery. Earlier, I had termed the surgery as uniting the non-union patella. Now I termed it as re-establishing the extension power in a non-union. Then I rationalized the surgery. Patella is a cancellous bone. Cancellous bone healed with compression only. I think that Charles' situation is very well known to us. So in a patella, it being cancellous bone, it needs compression. When in a fresh fracture also, unless it is compressed, it doesn't heal up. That's the reason we give a tension bend. In non-union, central bone loss occurs in patella. Due to the shortening of the quadriceps, even after lengthening, patella cannot be brought end-to-end in a compression as in a fresh fracture. So the patella approximation is done radiologically without effective compression of the cancellous bone. As you can see, none of them, you can see real compression except one case which I will show you. Fixation and wiring the patella, neutralizing wire from patella to tibial tubercle helps allowing the extensor expansion to heal and establish the knee extension. Once the knee gains 90-degree, wires get stretched and breaks. Patella now forcibly kept in contact, now pulled up by the rectus, proving non-union. Expansion is healed by then, so power in the extension is regained. To me, unexpected, unsuccessful surgery of non-union results in success to my surprise. Now here it is, you can see 5 months post-injury. Suturing was done, it healed up 6 months. This is the only one which actually healed up, as I said. None other healed up, all of them went into non-union. But this is the one you can see intraoperative also, good fixation and a good compression was achieved. Now here is this Dr. Shah. This is day 1, this is a small piece, same thing which was done. And over the time, in a non-union, this is a 1 month, it went into non-union. Now, this is the one in 3 months' time, non-union was retreated along with this, but you can see this, there is still a non-union. 3 months after second surgery. But you see, surprise of surprise, good active extension. Now here is this case, the same situation. 9 months. This is the one non-union. Now this is the Fatima post-op. Post-op, this is the one after 8 months post-op. 8 months, terrible X-ray, good function, power 4. Now these are so old in 2002 and 89. So some of those videos which I had taken at that time, they are non-working just now. So I could really put those videos. Here is this 1 year full power, full movement. You can see still a non-union. Here it is still, this is the one which is reconstructed. This is what is the treatment as I mentioned to you. Here it is the one, this is the, you can see the complete one, non-union, CT scan, the MRI, you can see the gap which is here, 5 months post-injury. This is not my case, I think somebody has sent me over with this screw, tension band, K-wire, and I was asked no TKR. No, here also, he wrote to me, this is the patient had about 100 degree of range of movement they gave. Now here is Dr. Bijlani's case. Yeah, that is Dr. Bijlani's case. Severe osteoarthritis says the patient doesn't want TKR. So I described him the surgery. He executed it. This is the 4 months injury extension leg Bharge. This is one is the left side, other is the right side. This is the one side which is operated upon. Now this is the one, 22 years, left side. This is the one which was, you can see the gap. Now 22 years, this is the one which was operated. This is the non-union and the knee is perfectly okay. Even the articular cartilage and everything, 22 years. Now here is the right side. There was no leg extension, so no surgery was done. Same knee needed TKR after 22 years. You can see now TKR. This is the Pakka non-union. 4 months full. TKR, Pakka non-union, you can see. So it was the left side was operated and the right side, the TKR was done. Along with the non-union patella, 22 years after. And you can see this is the typical TKR. So earlier X-ray which I had shown was the same patient. But as I said, I didn't have that earlier X-ray. This is what is after a TKR. You can see he can do it very well. He has a good extension power. Here it is. These are the muscles which are working. Vastus medialis, vastus distalis, iliac tibiobene and rectus femoris. These are the 4 muscles which are responsible and they all attach by this device. So it is not only the patella which is working, but it is all this expansion which is the most important part. So in conclusion, non-union patella expansion is the key. Patella is approximated for expansion to heal. Patella may end up in a non-union, but the extension is restored. Thank you very much. So I feel this is the one which many years back I had this series of cases, which somewhere in the paper it has been reported. I went through the literature. Not many cases, not big series of a non-union of patella have been recorded. Now, if I remember at that time, 2 series of 5 and 4 patients were recorded. But now here, since I didn't have the videos which are functioning very well, so that's the reason I couldn't give the videos. But all of them, I had taken the videos in that time. But now today's format, I think they are not working at all. Thank you very much.
Thank you, Tanna sir. It was indeed a innovative talk. That was also a nice concept explained. Any questions for Dr. Tanna sir? Any questions?
I think now there is a possibility of doing a plate and tension band wired together with the non-union. Is there a possibility, sir, with the hook type?
Possible,
plate?
but as you can see, I could hardly ever get the compression of the patella.
Right.
Because you do not want to fishtail it, you don't want to elongate the rear rectus.
Right.
So if you elongate the rectus, you will lose the power of the rectus. So initially also I said, I'll just do this. And to my surprise, when the expansion was future, I got the good result out of that. So today probably, it wasn't planned. It was just an observation which we got. Today I would think about it. Do whatever you want to do to the patella, but give main pressure to the expansion and get the expansion going.
So the expansion has more power than the retaining bone, Patellar.
Probably the equal power, I would say.
Yeah. The fantastic message, sir. Difficult cases.
This is how as it happens, some odd cases come in a wind. So 5, 6, 7 cases I came, and once I presented, people from different part of the India, they sent me these cases. So that's why some of them were mine, but not all of them, as I have shown you.
Yes, sir. Difficult to get non-unions. I had only one non-union I treated till now.
Okay, friends. Thank you.
So now, what is
So Abhijit?
Yeah, so the next talk, we move to the next talk, which is on lateral, which is on the tibial condyle fracture. And this will be delivered by none other than Dr. Jignesh Pandya. Over to you, Dr. Pandya.
Hello, good evening.
We can see. Yeah, we can see. Yes.
We can
Good
see.
evening.
Make it full screen, lower down.
Yeah.
Yes.
Okay.
Yes, perfect.
My talk is the evolution of tibial condylar fracture fixation. So we have to run for an evolution with the time. So proximal tibial fracture is always a topic of debate. So we need to understand this fracture pattern with X-ray and CT correlation. If we can understand it, then we can use the different approaches and implant available to fix all these fractures. There are 3 major developments in field of orthopedics. One is technology. We have got new implant and instruments, and we have got mini fragment implant plates, long screws available in a small diameter. So a lot of fragments can be fixed, and a lot of fractures can be fixed with the multiple implants. Where anesthesia, that is we can approach a different position, we can prone, supine, and we can change the position during surgery. So that is also one major development. And best and biggest is the imaging study, which has changed total understanding of tibial condylar fractures, or say per se all the fractures in total, pelvic fractures, upper and humerus fracture, everywhere. It has totally changed the understanding of surgeons and outcome of all the fractures. So first I will go with the X-ray, this AP view. But the later view is telling the different story. Very, very important to understand both the views. So these 3 pictures, the lion is eating the cub, somebody has amputated the head, and somebody is telling some bad word. But if you see the other view, lion is carrying the cub, and that man is telling something good. So 2 views are very, very important in orthopedics. Either they are obliques or they are epilateral plane. So first, we are all mesmerized by this classification, and we were followed for years together. But it is actually an AP plane classification. There is no picture of lateral view. So coronal plane or lateral plane fractures are not described. So we have to understand this tibial condylar fracture in a 3 dimensions, and we need to understand coronal fractures. So even if you see AO classification, that is also AP plane classification. CT not included at the time, coronal plane not included, and there included extraarticular fractures in type A. So now we need to understand this column classification and interarticular coronal plane fractures. If you understand that, then we can run for a newer development of the fracture fixation technique and how to do the newer approaches. So first described in 2013 by 3 column concept. 3 condyle, medial condyle, lateral condyle, but both the condyle have got posterior condyle. So they are posteromedial part and posterolateral part. And if we understand these 3 columns, then we can almost understand most of the fractures of this. Now they are further device classifications are there. Dr. Sadgar with Mauricio Kufri has given a CT-based extension of the old Saskar classification, and it is a little bit cumbersome to understand, but one can read the article for 2 hours and get easily idea that what does this want to tell. And one more is 10 segment classification, which I will go later. So But this will definitely make clear understanding of fracture morphology. If you understand fracture morphology, then we can run with the time to do better fracture fixation and understanding. See this, suspicion is the best diagnostic tool. So this simple looking X-ray, but if we see the arrow, there is something wrong. So if we get CT scan done, and we can see this has got ACL avulsion, medial condyle with posterior apex, and posterolateral condyle impacts. So if we understand this, then we can take a proper approach. The posteromedial approach was taken, buttress plating was done. ACL was a small fragment, so left alone. Posterolateral impaction did not require any address and got a fantastic functional outcome. Another, these two are identical cases. If you see epilateral X-ray, they are looking same condyle fracture. Okay. So this is CT scan showing this fracture. There is something suspicious in lateral condyle in both the cases. And this is CT scan. So both the CT scan, if you see lateral view, one is anterior depression, compression, fracture of lateral condyle, and second is posterior, right side is posterior. So it requires anterior approach, and this requires posterolateral approach. So one is behind the fibula head, another is anterior, anterolateral. So if we understand this with CT scan, by reading coronal images as well as the 3D CT morphology images, we cannot make an approach decision. So CT scan is must, even if you want to treat the fracture conservatively, to prove that this has no other deeper injury or major injury, we have to get CT scan to rule out any other major intra-articular depressions. Now, there is something wrong with lateral condyle. One can, and hemarthrosis is there. But if you see CT scan, it is completely depressed, compressed fracture of posterior condyle with increased slope and exactly over the head of the fibula. So how do we go inside? So if somebody wants to go anteriorly, anterolateral approach, we have to break the condyle completely. We can reach to the fracture by submeniscal arthrotomy, and we can put a wrap plate with 4 screws. But none of the screw will support this much posterior part of the lateral condyle, which is around the fibula head. So it is not a good idea to do like that. So if we go direct posterolateral approach in prone position, we can see the fracture line like this. This articular surface is seen in front of your eyes. We can directly elevate it, put a buttress plate like this. All the screws are supporting the fracture depression, and the plate is putting like this on bone model. You can see just by the side of the facet for the attachment of fibula head. All the 3 screws will be parallel to joint line, and they will look like this in the X-ray. So the same case which I showed, operated by posterolateral approach. This is the plate placement. This is intra-op pictures, and that's the functional outcome at 4 weeks. Full movement in just 1.5 month time, 1 month time. So that's the outcome. So this is a bicondyle fracture. See, this is a very common scenario. You see bicondyle fracture, but this is a medial condyle is coronal plane fracture, and there is a lateral condyle fracture. Surgeon treated with the 2 plates. One is medial, one is lateral. So what happens? Anteromedial plate is there on medial side. It has not fixed this medial condyle fracture. This lateral plate, it has not caught that fragment. What happens? This fragment will live left alone, flying. So none of the screw from any of the 2 plates could catch up this fragment and reduce it. So this anteromedial plate, how it goes? It goes like this. So not a good idea to do in a medial or posteromedial area with the anteromedial plate. This now somebody wants to do lateral plate and lat screw. The lat screw cannot pull this fragment. It needs a shear fracture, so it needs a buttress plating. So this is not again a good idea. So lat screw principle is not applicable in the posteromedial area. So not a good idea. The best thing, go directly, reduce the fracture, put direct plate, buttress plate like this, and have a peace of mind. 100% reduction and perfect fixation can be achieved with excellent stability. Now, so this is the similar example, posteromedial coronal plane fracture, you can see here, and that was operated by direct posteromedial approach, and you can see the buttress plating and fixation. So these fractures are not good to operate by medial plate, they are good for posteromedial plate as a coronal plane fracture. Now, we have to identify and understand medial condyle fracture. Both are medial condyle fracture, but one is in sagittal plane, another one is in coronal plane. So sagittal plane fracture, just medial buttress plate, and you get away with it. And this is posteromedial approach required because it is intra-articular posteromedial fracture. Another one, medial condyle fracture. Again, we have to identify. Both are posterior apex fracture, but one is coronal plane fracture, another one is total condyle fracture. This is total medial condyle fracture with posteromedial apex, and these fractures will have associated posterior condyle and AC level done in 95% of the cases. So we have to understand this, that when you see such pattern in the medial condyle fracture, always get a CT scan, properly study of the CT scan will give an idea that how to approach and how to do the surgery in this case. So you see the fixation, left side, only coronal plane fracture, just the posteromedial buttress plate, and you are out. Here, total medial condyle need double plane fixation with posterior elevation and fixation, 3 plates. So it changes the scenario and fixation pattern in totally differently in both the cases. Though later we showing the apex posteromedially. Now, these are another one. These 2 different type of fracture as per mechanism of injury. This both will have medial condyle fracture. Varus force in extension and varus force in flexion. So varus force in extension, they get reduced very well in a just give traction, and their sagittal plane fracture, they fall into place, percutaneous clamp, and a plate fixation can just get out of the situation. But varus force in flexion is a bad injury. It will have a complete total medial or posteromedial condyle fracture, subluxation of the knee joint with impaction of the posterior condyle and AC levels. This is classic pattern. If it is treated like an extension variety, like this plate is pushed medially, and that to a lateral side, the hockey plate is pushed on medial side. So, you know, you can see just implant there, but the pre-op and post-op same X-ray. Because reduction is not done. Tibia is subluxated outside, and medial plate is doing nothing. Varus is there, and that lag screw is not catching the medial fragment. Nothing is done. So, if the fracture is not understood properly, then we can have a bad fixation and bad outcome and bad result for the patient. So, this needs to be understood that which pattern of the injury is there, and then we can plan out. So, this is what is, we are doing the same thing for all tibial condyle fracture, but just we are improving the understanding. What is new evolution? Is evolution of understanding of the fracture, and using the same implants can be done, but if you understand the fracture, that each type of variety of fracture, that we have to reverse all the steps and forces, and we can just get away with a perfect outcome. Now, this total medial condyle fracture with double apex. This I will show you. See this. So CT scan. This posteriorly there is one spike and there is medial spike. Medial spike is inside. So varus is there and posterior spike is out. So it is classic tilting of medial condyle. It is a total medial condyle fracture, and you can see there is little bit subluxation of the lateral condyle. So it is actually a fracture subluxation of the medial condylar fractures, and there is always an ACL avulsion associated. If it is a large fragment, you need fixation. A small tiny fragment can be left alone. They doesn't give any instability. So this is, you can see medial condyle with dual apex, medial apex and posterior apex, right? So this condyle needs reduction in both the planes. So single plane reduction will definitely under reduce the fracture. So first you put posterior medial plate, reduce the condyle. So posterior apex is reduced. Now correct the varus. Get intercondylar compression. Here we need to because there is no coronal plane fracture, but we need intercondylar compression proximally. Distally it is double apex, but proximally it is single large condyle in coronal plane. So intercondylar compression. Then rest of the screws proximally and distally. Now we will see this. What happens? This fracture, very typical pattern. I had a picture. Sequence is there. This is the varus. Once you put a posterior plate, posterior reduction is achieved, but posterior cortex reduced. The tilting varus. So correct the varus with a joystick. Use a 2.5 mm thick wire or a thin ST beam, 3 mm ST beam. Elevate and correct varus. Now you can align the medial cortex perfectly well. Then put one guide wire from lateral to medial side or medial to lateral side. But put the screw from lateral to medial because you want to avoid MCL entrapment by the screw from medial to lateral. So put partial threaded screw which crosses the fracture zone. So 32 mm screw will be good enough with washer from lateral side. That will definitely catch in a subcondylar region and compress the condyle perfectly well. Then put rest of the screws and you will see the post-op fracture perfectly reduced and aligned fracture. So If we understand the fracture very well, then we can plan our steps of the surgery, and that's the evolution. Another case, similar case, you can see sublex of the lateral condyle, and there is a medial condyle fracture in double apex. Again, there is a medial set comminution is also there. Posterior medial comminution is also there at the apex. And again, in a similar manner, dual apex with comminution, it needs double plane fixation. So double plane is one is the screw, one, or you can use two plates, but we can avoid one plate by doing this screw fixation method. So that's again same way, intercondylar screw and the rest of the screws. See, there are the steps given. Then again similar way, put plate posteromedially, correct posteromedial apex reduction. Then don't put proximal screws, get intercondylar compression and reduction, and then put rest of the screws. So, and that the follow-up, that there is no virus, perfect reduction and full function is achieved in just 2.5 months. So management changes with the time. The upper one, left side, is a picture from the Sadgar book, 1987. And lower one is a X-ray, recent X-ray. Similar injury. See, there is a medial condyle fracture with the femur. Usually, medial condyle doesn't leave the femur. It's a strong attachment with that. But lateral condyle always subluxate anterolaterally out. So this is subluxation, dislocation of the knee joint, partial dislocation, I will say. Half, a whole shaft with the lateral condyle goes out. And see, they have treated with the medial plate. But you can see the posterior apex. Posteriorly, it is open. The posterior reduction is not done, not possible from medial plate. And here, we have posterior plate with the PCL screw, which was there, fragment was there. So, it took about 30 years to move the plate from medial to posterior surface. To understand this evolution, that how this fracture behaves and how it should be, can be 100% reduced by using the different approach and a different plate. And plate on a different surface. So now we have to understand this. Total medial condyle fracture with partial lateral plate fracture. So left upper corner, if you see, this is medial condyle fracture, but intra-articular, it is a lateral condyle fracture. Lower down, this has moved, this lateral line has moved in intercondylar region. So the apex is moved from medial to posteriorly. So whenever there is a sagittal plane fracture, fracture in the medial condyle, usually it will have double apex or a double posterior apex, but cannot have anteromedial apex. And it will definitely have associated posterolateral condyle impaction. Which may not need address or we may need address, depending on the type of the depression and involvement of the articular surface. And ACL eversion will be a common scenario. And the third picture will be a classic posterior bicondylar tibia with posterior apex of the posteromedial condyle coronal plane, ACL eversion, and impaction and depression of the posterior condyle, which can be addressed through a single approach. So this is how we understand the CT scan and morphology of the fracture pattern, and we can plan our whole approach and the treatment. So this is again the same thing which I saw the picture. This patient has got subluxation of the lateral condyle, medial condyle fracture, and ACL eversion. And you can see there is a depression of the posterior condyle. Femur is digging into the lateral condyle, giving the depression of the posterior condyle. So you can, this is total medial condyle, shear fracture, but classic posterior medial apex, medial apex as well as the posterior apex. And there is a depression of the posterior condyle. It was treated classically like that because it was a total medial condyle, not a coronal plane fracture. So did double plane fixation for this condyle and another plate for the posterior condyle. And that's the outcome. Perfect reduction, full function was achieved. Now I've got almost 7-8 years follow-up of this patient. This is again a posterior bicondylar tibia fractures. See X-ray, it looks that there is simple injury. But if you see CT scan, in 2D CT you can see it is total posterior column injury and there is nothing anteriorly. And there is a depression of the posterior condyle, large posterior medial fragment in a coronal plane with a ACL eversion, and PCL is a part of the posterior medial condyle. So this is very complex, bad injury of this patient. But X-ray doesn't look that bad. So what is the planning? How will you plan this? So first we will do posterior medial approach because this is a coronal plane fracture, both the condyle posteriorly. So can be easily done by extended posterior medial approach and everything can be fixed from one single approach in prone position. Here nobody can do from anterior, not possible. So we have to have a direct approach and direct reduction and fixation. So first, reduce posterior medial condyle. You cannot approach posterior condyle without reduction of posterior medial condyle. Posterior medial reduce, so we'll reduce the subluxation of the whole tibia from anterior to posterior and reduce with the condyle. This is a key fragment because femur is with the small posteromedial condyle. So that is determining the axis of the knee joint. So posteromedial small fragment needs to be reduced perfectly 100% with the shaft of the tibia. Once you get it, the alignment is achieved, then you can do posterior condyle. It will be in front of your eyes and elevated fixation can be done. Then first buttress leading, first screw at the apex, then rest of the screw, get perfect reduction. Then elevate posterior condyle, pull a feeler or a graft, whatever. Then posterior plate and rest of the screw. This is the pattern of injury which this patient has got. Posteromedial, both coronal plane fracture. And this is intra picture, both plate very nicely adjusted. And this is the fixation and postoperative X-ray. Now, this again a complex lateral condylar fractures, only lateral condylar fracture. So, is this reduction acceptable? Plating is done. Surgeon thought that there is some lateral commission posteriorly. They put, you can see wrap plate quite posteriorly fixed, very much posteriorly. Anterior half is almost left. It needs improvement. If you see pre-op and post-op X-ray, they are same. There is the same step is there in lateral condyle and everything. So, what is actually CT scan? If you see this patient CT scan, this is the CT scan of the same patient. Large posterior condyle, which was left without, I mean, it must not have fixed because the plate is still anterior to the fibula head. So, none of the screw must be fixing this fragment and posterior subluxation is not corrected. You see the posterior condyle at the fibula head in the previous picture, subluxating posteriorly. So, what happens here? Lateral plate cannot fix this fragment. This will be left behind. So, what should we do? We should take an approach which allows access to both the part of the condyle. So, Frost approach should be that, I mean, the idea to do this in this case. So, first fix posterolaterally. That will give a template for reduction of the anterolateral condyle. And we can easily see posterior reduction through anterolateral submeniscal arthroderm. And then fix lateral plate, and it will give a perfect anatomical reduction. See similar case. There is no injury on medial side. It is a lateral condyle commuter fracture. You posteriorly, there are two parts of posterior condyle. One part is a part of the PCL, and there is a depression of the lateral condyle anterolaterally. Anterolateral split is there, depression is there. So lateral condyle almost in 3-4 pieces. And lateral position, cross approach, direct approach, double window. First posterolateral plate, you can see the reduction achieved, slope is achieved, and immediate post-op, perfect reduction and alignment of the posterior lateral condyle is achieved. And that is the follow-up action. So, if we understand this fracture, it needs two parts to be fixed with two different plates, then can be very well done. So, this I was talking about, this intra-articular tibial plate fracture characteristic, 10 segment classification. They have divided this fracture. This is 246 cases study, 2016 article injury, and anteromedial, medial, posteromedial, medial, anteromedial, central, posteromedial, central. So this, if you classify this fracture in coronal plane, this includes up to 3 centimeters of the bone, then we can decide the approach, then which approach can lead to this particular segment. So you cannot make a mistake of going anterior or posterior, and you can plan your approach and fixation pattern by selecting these segments, which are the segments involved in this fracture. So better to study 2D CT coronal plane fracture. And what they said, posterior segments are most frequently fractured in OTA, AO type B and C fractures. Very common. B and C type B, C, AO, very common. They are almost, they have noted that it is 42% incidence of posterior fragments. Acknowledging the restricted visibility of posterior segments, whose reduction and fixation is crucial for long-term success, our finding implicate the use of posterior approaches more often in the treatment of tibial plate fracture. That is the conclusion. The finding of a commuter medial articular surface in low energy trauma indicates potential challenges to properly reconstruct the medial tibial plate in future because it requires a posterior approach. So this is the evolution, that there are different approaches to tibial condyle now. Initially, it was only one median approach, and anteromedial and anterolateral. Now, Frost, suprafibular added, posterolateral added, posteromedial and extended posteromedial added. So all are approaches which are new, and that's the evolution in fixation of the tibial condylar fractures, and that we have, by a better understanding of the pattern of the fracture, we can decide our approach and plan our surgery. I cannot teach anybody anything. I can only make them think. Thank you very much.
Thank you, Dr. Pandya.
Thank you.
Thank you for a wonderful, yeah. It was an excellent, a wonderful talk. Probably you can't simplify more than this. So many cases you had on your platter, and you did analyze them well and even fix them equally well. Any questions for Dr. Pandya?
So if I can ask, Jignesh,
Please, sir.
most of the medial condylar fracture you have preferred to put a posterior plate and a lateral to medial screw. So is it more wiser to put a medial plate as well, or
Sir,
you are happy?
Sir, initially I used to put double plate. I have got a lot of cases of double plate also. But then I thought that I can avoid one more plate and dissection also. Because medial plate you have to always put on an MCL.
Mm-hmm. So any
I
problem?
wanted to avoid that.
So
I wanted to improve number of implants. I wanted to reduce
morbidity
of the approach because dissecting more on medial side unnecessarily. If I can get away with single screw, then what is wrong in that? So I have just changed over to that.
Any problem with the medial plate on MCL you feel?
No. I did not find any problem. But I was just thinking myself that if I can avoid one medial plate, so less implant, one more, no dissection on further dissection on medial surface, and I can just get away with one single screw. That is very easy to do.
Okay, perfect.
Because
so I started with double plate, sir, but gradually I doing two screw. So I was happy with that.
Because
Yes, sir.
There is a one possibility. Then the more the soft tissues are involved, the more the function probably problem.
Maybe, sir.
And the strength of the muscle and everything. That is also a possibility.
Dhaval sir wanted to say something.
Yeah, Jignesh is a very interesting question for you.
Please.
I know that you know, but it's not enough that you know for the rest of the country. So, having seen a lot of not well fixed tibial condyle fractures, I'm going to show some of these on the next another thing. So, what do you think would be the best way to treat or teach this fracture? You say you can't teach in your last line or last statement, but I'm sure you now that you are this thing, you must devise something to teach this fracture to people to understand this. Do you have any thoughts on this?
Yeah, what we can do is the best thing is the case examples. You put more identical cases, and people should go for a more on a workshop, hands-on workshop, and understand what is buttress plate, what are shear fractures, and how it can be neutralized, and which are the forces acting, how to understand the fracture. If then we can make somebody wants to learn, then he can do it. If somebody doesn't want to learn and do it on his own way, it's very difficult.
Maybe you should have a basic course of only X-rays and CT understanding perhaps before you are allowed to operate.
I think so. But people want to learn only surgical technique. They don't want to learn. Theory part, the people don't like.
And they want to learn the approach.
So
they ask only on which side should I put a plate.
So Dhaval sir, AO course on only tibial condyle fracture is a possibility?
I honestly think there should be. I think the Ioa is sort of, because we are on the Ioa webinar. I think this is a huge need-based fracture. If you see around, this is one fracture that gets botched up quite well because of not understanding the fracture. It's not that people can't operate, but sometimes just the understanding is not good enough. And I think we should devise something on that basis. I really think we could.
Till that time, somebody puts the case discussion so that we.
Dhaval bhai, you have a. Dhaval bhai, I invite you for the VIROC for presenting a symposium on proximal tibial fractures.
Oh, sure, but then we will probably keep two level of understanding, as I tell Jignesh. If you just teach them to operate, I will show you, even when you operate, there are even enough disasters. Let me come to my cases a little later on. But we can improve, and we can do something good for sure.
Dhaval bhai is having a very fresh case of proximal tibia which has been operated, and he is going to present probably today.
Anyway, very interesting talk, Jignesh. But as I said, it's not enough that you know.
I always try to simplify. I have put animations and everything. So I think I tried definitely my level best to put very simplified manner to how to understand the fracture and all these things. But in 15-30 minutes is always less time to explain everything in tibial condylar fractures.
True,
yes.
sir. May I ask Dr. Gadegone sir to share his screen till the
Yes,
time?
sir. Yes, sir. I will share screen. And
may I also ask Dr. Tanna sir and Dr. Chandak sir to moderate this session? We'll continue with the Kale discussion till 7:45 p.m. Whatever best number of cases we can cover till that time.
Yeah.
We'll try to do.
Meanwhile, there are 2 or 3 questions. Dr. Tanna sir, Dr. Dwarkadas Tapadia has asked you. Tanna sir, are you there? Hello?
Yes, sir. He's logged in. Probably sir has muted.
Okay. But
sir,
listening or not? Okay.
my screen is visible.
Yeah, Gadegone sir, we can see your screen.
Go ahead, sir. Go ahead, sir.
सर वो जिग्नेश जी मुझे माफ करना.
माफी granted, sir. Go ahead.
सर जी ऐसा मत बोलिए आप हमारा गुरु है गुरु.
So this is a case presented to me, 62-year male with this picture in a corona time, and I asked him to get it admitted for this surgery, and then he said कि नहीं मैं गांव से आता हूँ. Then after the history, it was found a motor vehicular accident presented after 2 days of trauma with these all blisters, diabetic on insulin and hypertensive, distal no neurovascular deficit. Now, as you, Dr. Jignesh, you must do a CT scan, but this patient was not, actually I advised him, but he was not willing to do that. And then even not admitted also on the same day. But the next day, what is after 2 days of this is the picture, and he came again for the admission. Pain at the fracture site, painful movement were present, peripheral circulation was positive. The blood pool and forms of a blister that damages the lower layer of the skin. And you can see here, these are all hemorrhagic blisters. Patient is diabetic, and his HB1C, it was near about 9.3. And in such a situation, what to do? So this is the patient open for all dignitaries to discuss.
So now it's the compartment is starting, I think, the way you are describing.
So
can you share the X-ray, pre-op X-ray, keep that on the screen and we can discuss on that X-ray?
Yeah, this is the X-ray. This is the X-ray. You can see all fracture fragmented. On lateral side, there is a medial, posteromedial. It is a global fracture, you can say. It's a global fracture. It's a global fracture, difficult to define.
Multi-column. It is a multi-column fracture, but articular surface is not very badly crushed. Basically, crushing is at the metaphyseal region.
Here you can see that
he is likely to get a good result at the end.
Can we say on the X-ray that there is no articular involvement? Without CT scan, it is very difficult. Many times these fragments go in.
Sir, you can read X-ray very carefully, and there is joint space is maintained.
There are all
there is coronal plane fracture. It is fracture type 6.
There are both. There are lateral condylar fracture as well as
medial condylar fracture. Yeah, he might be having 4 column, all column fracture. All 4 fragment of articular surface must be there.
Yes.
So more important than that, the soft tissue management would be really very crucial for this patient.
That is the key. That is the
key. Otherwise, it is good.
Success of this case, ideally.
Yeah. So Gadegone sir, amongst the philosophies of external fixator versus a back slab, what would be your philosophy in managing this patient?
So what I did, actually, this is the fracture. So I have actually necessity may be the mother of invention, but ingenuity is the bombshell of success. So this is the panic can also be the mother of invention. You can say I was in the panic, what to do, whether to do external fixator, skeletal traction, what to do about the blebs. Already is a diabetic, probably may go in septicemia, 62 years old. There are so many problems, and whether to keep this patient with me or send it to Dr. Chandak for a wiser treatment. That was a dilemma. So you can say here what I did under anesthesia, dressing plus skeletal traction, elevation, and broad spectrum antibiotics to reduce swelling and blister. That's what I did. And the Gauti method, you can say here, it's not a a very sophisticated treatment like a Jignesh bhai. So what I did, this is the picture. This is, we can see here. And then that is my philosophy is extent of damage is often greater than indicated in X-ray. 8 patient frequently does better than 1 prognosticate. So if you allow me in the next time, I will show at least 20 cases where the failed fixation and failed reduction also, they are doing well. The God is great. There is universal agreement that the accurate restoration of joint surface, stable fixation, and early motion are important. Everybody agrees it, and it will learn also. But anatomical reduction of metaphysis is not necessary and may increase the surgical morbidity. That is what literature says. So this is how it is. This is the 3 agreements are there. And then probable risk factor in this case, advanced age, multi-pronged fracture, smoking, comorbidity in patient, diabetes and ISD, and skin at the risk. Knowing all that, why to invite the trouble of implantation of a metal in such a bad case? And that was my philosophy. And therefore, I remember my old, when I was a lecturer in the government medical college and published a paper, that time the plates were not there and the understanding of the subject was also not there. The treatment of fractures of the tibial plateau by skeletal traction and early mobilization. And we concluded that the conservative manage is a valid alternative to surgery, but should probably resort for cases where operative treatment is undesirable. And this is published in 1985 in the SICOT International. And this is my Guru Vikram Marwa and Vasudev Gadegone. This is already published in a international literature. So what I did, after 15 days, healing of blisters, and I planned a biological reconstruction of this patient. So what I did, after 15 days healing of a blisters, biological reconstruction and adjuvant screw and elastic nailing. So I passed nails from the retrograde, from the supramalleolar region, and then I passed it in the all corners of this femoral tibial condyle, and the articular stability is given by 2 screws spacing up near about 1 centimeter apart. So what is my philosophy is to support the subchondral bone of the proximal fragment by antegrade intramedullary elastic wire till the fracture union. So it is like Hanumanji, what is, you are not getting a specific medicine in that parvat, so that what you do, pura ka pura hi leke utha ke leke aao. It is like that I am supporting with the multiple wires, the whatever they are, the pieces are there. That is my philosophy. 9-month follow-up of a radiological and functional outcome. You can see the telltale evidence of all that is blisters are healed. This is 3 months, 9 months follow-up. And then you can see here what type of a plate will give anterior, posterior, medial plateau. This is the functional outcome of this patient. So my dear friend, don't go on a fracture specific multiple fixation. Probably you may invite trouble of infection or neurovascular deficit by younger generation who are not very trained. And if you minimally invasive surgery like this, a skeletal traction, early mobilization, and just condylar support probably gives a best result. Another example, I can go. So this fracture would have been treated by, should this fracture would have been treated by open reduction and internal fixation? Yes, it can be done. Maybe our Ilijaro method, but not all severely displaced fracture did badly on limited fixation on traction. Somewhere surprisingly did very good. This is the literature, and this is the apply where it is the quoting from his book on the fractures of the tibia. Another case, this is how it is, a 56-year male with a Sarger type. You can see here, this is the fracture. And you can see this is the skin. burnout, unhealthy skin over the leg, and the proximal tibial fracture. So there is no place that the skin is, this is stuck to the bone. There is no flexibility of the skin or the proximal tibia. And you can see this is the type of a fracture. So what should be done in this case?
Any opinions you want to
Yes,
add?
yes, because we are discussing this case.
Yeah.
Suppose it's a situation, because it is you can see these are not, actually he has the burn and take near about 1 year to heal all these things, and probably the skin condition is very, very bad, and this type of a fracture it is there. He is a 56-year male, no comorbidities. He is not a non-diabetic, nothing.
So in this case, since the skin is not suitable for tunneling of plate, I would use an external fixator to manage him. An external fixator which is quite comfortable for patient to carry on for at least 3 to 6 months. And the best I would consider is an extracutaneous plate, providing good reduction and early mobilization.
But how will you reduce this fracture, sir?
So this can be reduced very well with the tongue and percutaneous method. So by 3 screws in the subchondral level, 3 wires, sustentacular wires, getting the reduction, adding tongs from both the sides, getting the reduction first, 2 subchondral screws, and then an extracutaneous plate.
And
So
what about this Jignesh Bhai fracture?
Yeah, that also can be managed by that screw going posteriorly through the plate which holds this fragment as well. So we'll select that.
So you will probably buttress by the screws only, minimally invasive small incisions and screws. Dr. Gadegana sir, probably. And metaphyseal region you are going to support with the flexible nails again.
So what I did, these are all CT scan, actually is not a very, so we can see the same procedure. What I did is a retrograde,
we do
and the screw traction, manipulation, clamp, and Steinman pin assisted reduction, percutaneous retrograde wires, and percutaneous CC screw fixation of tibial plateau. You can see here, and this is the post-operative X-ray after 3 months. I think so.
There is also one Ender's nail from the top also.
Yes, to support the medial fragment, so that there should not be any varus collapse.
So these are all done on the fracture table. When you give a traction on the fracture table, automatically soft tissue attachments give you a good amount of reduction.
So this was done like this, and you can see the amount of the ugly scar and everything was there with the percutaneous incision. I have done it, and after 3 months, you can see here, everything is healing. Posterior condyle is in place. Medial condyle is still to unite, but on the laterally, the condyle alignment was good. No change in position of wires in 3 months. 9 months follow-up. You can see how the remodeling of all fracture fragment have occurred, and he is able to see it, and you can see here how the skin is there. I have given a very small incision here and a very small incision on this side, and then radiological, and actually, and this is the functional result of this patient, a 9-month follow-up. I think so. I have done a best job. So the articular reconstruction is a mandatory thing. Metaphyseal fragment reduction and fixation is not that mandatory what literature says, but I have seen number of patients, they do better even if there is an articular injury. And I have also got the reports from the joint replacement surgeon that I asked them how your incidence of osteoarthritis secondary leading to the joint replacement, and they said that the 95% is a primary osteoarthritis, 5 to 10% only requires a joint replacement surgeon. On an old failed surgery of upper tibial fracture, it is rarely the patient come for joint replacement, and that is not the literature, but I have asked to a very famous joint replacement surgeon So we have to rethink that all fracture fixation from posterior, anterior, medial, lateral, is it a very necessary thing? A ligamentiotaxis and early mobilization, as Graham aptly said, gives equally a good functional reduction, though anatomical variation and some 2 to 4 degree of virus and vulgus, it is acceptable to the patient. So I have a number of cases to say. I have cleavage reduction, stabilization. It is these are all theoretical, but in conclusion, practically, it's a simple method with threefold advantages: surgical, mechanical, and biological. When major surgical procedure may do more harm than good with the unexperienced hand. And there are other cases also to share, and you can see here, but I will stop here. And if you will see that there are so many amazing cases with me, but they are pravahacha viruddha. I am flowing against the whatever the flow is there, and therefore it may not be acceptable and palatable to the all masters, those who are sitting.
This is also possibility, sir. Yes, this is also possibility. Science is a possibility, nothing else.
So thank you, Abhijit. आपको बोला था मैंने, I will produce something unusual orthopedic.
Always.
टन्ना सर मेरे तरफ गुस्से से देख रहे हैं.
क्या करे अभी, ऐसा तो बोलता है तो.
मैजिशियन.
एक मिनट, ऐसा कितना केस किया है तू?
मेरे पास होंगे 10 केसेस.
All of them succeeded.
नहीं, ऐसा कुछ नहीं है. That sometimes they require some revision surgery also.
Because you are selling something which is coming totally contrary to the belief.
इसलिए तो मैं पहले परमिशन लिया.
नहीं, परमिशन नहीं. Permission, Abhijit का permission लिया, that is fine. But whether this is the message you want to give it to everybody.
No, I don't. But this can be treated, and I have got a very good result. और आप अगले बार बोलेंगे तो मैं 10 केस इजीली दिखा.
सर मेरे पास भी 6 केस हैं सर, मैं भी आपके साथ कंबाइन कर सकता हूँ.
The message is possibly this is under constrained situation where the choice of internal fixation is not likely to give a good result or likely to have a bad outcome. Is that the message?
Only the message is when there are more possibilities of harm by doing internal fixation. This is a one possibility where in an initial phase, at least it saves your alignment and everything. You may require a secondary procedures later on, but at that time, the primary procedure of pleating in different planes was not possible in his all cases.
Exactly. That's what I want to give the message. Exactly.
So, Abhijit, can we go for the next cases?
Gadegone sir. So basically, the metaphyseal varus prevention or axial alignment maintenance is the key to the success in your cases, along with articular reconstruction. Obviously, you are using some logic and science in these fixations.
So I will show you some amazing cases of this minimal invasive treatment. आप चिंता मत करो. बहुत
नहीं, जो जितना देखा ट्रायल सैंपल ट्रेलर में तो समझ गए सर.
Right, it's a good option. Good option.
Abhijit,
yeah.
So
you may let allow others like Purohit sir or
over to the
Motwani.
second case, which is by Dr. Dhaval Desai. Over to you, sir.
Shall I? Are we running the full show?
So we'll be running the show till 7:45 p.m.
नहीं तो इसीलिए बोल रहा था, अगर किसी और को देने का तो दे दीजिए.
Dr. Motwani or those who have not got the chance. Dr. Motwani is there?
Sir, एक आपका केस.
डॉक्टर मोटवानी जी हैं या तो डॉक्टर हमारे
स्वप्निल
कोथड़िया जी. हाँ.
स्वप्निल को दे दो किसको. हाँ प्लीज, गिव देम चांस.
हम लोग तो बार बताते रहते हैं सर.
हम लोग तो.
Are we audible to you?
Swapnil, you are there?
Yes, sir, I'm here.
Go ahead, Swapnil. Go ahead. Go ahead.
So
please.
share your screen.
Okay, sir. Okay. So, good evening, respected seniors and my friends. So, again, my presentation will be totally against Dr. Gadegone sir's presentation. So, this is one of the difficult most case I have done in proximal tibia. So, this is all column fracture actually. A 45-year male patient had got a road traffic accident due to fall from bike, treated locally in form of some massage. Because it was a corona period, he didn't come to hospital and came after 15 days with skin swelling, blebs were present. At that time, Dr. Dantakai sir from Sholapur, he gave him supramedullary print traction till skin becomes normal, and then we decided to do this case. So you can see this is complete smashed out proximal tibia. And this is his CT scan 3D in all views, that is AP, lateral, posterior. Just a minute. So this is in AP view, this is in lateral view, this is in posterior view, and this is in medial. So from all sides, there is a complete fracture of proximal tibia. On the lateral side, again, there is a anterolateral fragment also. It is splitted in a coronal split. While there is a posterior lateral condyle, which is completely fractured and subluxated, which can be seen in 2D CT scan. So this is the 2D CT scan, which is showing this posterior posterolateral condyle, which is subluxated. As you can see, this is the articular surface. And here you can see again the same thing. So this is a difficult case according to me, where your all fragments, I mean, all stable parts, articular area has been completely smashed out. This is again coronal and axial view of the same case. So anyone who can suggest how to fix this? This is the assessment of the morphology which is done. This is anteromedial fragment. This is posteromedial fragment. This is posterolateral fragment. And this is the anterolateral fragment which is split. Again, there is a coronal split in this. So I think I will go ahead because we have constraint of time. So again, in MRI, there is a lateral meniscus injury also. So the lateral meniscus is also entrapped into the lateral comminuted fragments. So what I planned, wait till the edema subsides and the skin becomes normal. That is the wrinkle sign, which is most important in proximal tibia, which should be present. Then make a patient in prone position, then take a Lobenhofer approach to fix the whole posterior condyle. Fix first the posteromedial condyle and the medial condyle, and then reduce the posterolateral condyle and then fix it. So this is done for the posterior, posterolateral, posteromedial as well as medial condyle. Then take the suture and then turn the patient supine, and then take an anterolateral approach. Lateral meniscus has to be released from the entrapped position, and then the sutures are taken in lateral meniscus to suture it back. Then elevation of the depressed fragment on the lateral side, reduce the coronal split of the anterolateral fragment, and then fix it with a raft plate, and then the lateral meniscus repair is to be done. So this is my plan of surgery for this case. So the skin became normal, as we can see here. There are wrinkle signs which are present. Then through Lobenhofer approach, I fixed the medial condyle first and then the posteromedial condyle, as you can see here. This is the one plate. This is the second plate on the posteromedial side. And this is my spike, which is going to the lateral aspect of lateral tibial condyle from the posterior side. So once you put this spike here, the whole of the posterior condyle of the tibia, which is completely in front of you, and you can fix any type of fracture of the posterior condylar tibia from this side.
Here,
so this is the approach.
Here, why you have not pushed the screw proximally fully with the plate, buttress plate?
Plate. So the thing is, whenever all these plates are in buttressing mode. Okay, the proximal screw I usually use 25 or 30 centimeters in length. Sorry, millimeter in length, because when you are putting a lateral raft plate, okay, if you put these plates, these screws longer, then there are very high chances that it may fix the lateral condyle. When you make the patient,
I'm not asking that. I'm asking
yes, sir.
about. I'm asking about this area.
Which one? That's what I'm saying, sir. All these fragments, if you put it bicortical, Okay, either they are going to fix the lateral condyle piece. That's why.
Okay.
So then a posterolateral plate is also used, as you can see here. So all these three plates I can apply from the posterior side. That is the posterolateral plate, posteromedial plate, and the medial plate. And then lateral meniscus is isolated, as you can see here. Then stay sutures are taken in the lateral meniscus. This is the elevation of the depressed fragment. This is the anterolateral fragment. Window is made through that, open book made through that to see the lateral meniscus as well as depressed fragment, and these are elevated. Once they are elevated, they are fixed with the lateral laft plate. This is the intraoperative picture of C-arm in AP as well as lateral view, and this is the immediate post-operative X-ray, as you can see here. And this is 1 month follow-up of the same patient. This is 1 month follow-up of the same patient who is doing exercise. The advantage of fixing all the fragments is we can immediately mobilize the patient. So there is a complete extension and almost complete flexion. There is no neurovascular injury distally. Patient can do SLR also, and this is the flexion after 1 month. And this is the 1 year post-op X-ray of the same patient. As you can see here, the 4 plates are still intact, but there is 1 screw which was loosened out. This is 1 year post-op, range of movement. Patient is walking comfortably. And this is the second day of surgery after removal of 1 screw from the lateral side. And these are his range of movements. So this is 1 year follow-up of the same patient. So it is second day post-op of removal of screw. That's why he's a little bit walking like this. So thank you.
Fantastic. Fantastic.
So Abhijit,
Swapnil, if I can ask you, Swapnil.
Hello.
Swapnil.
Sir.
In your CT scan.
Yes, sir.
All those comminution was in the metaphyseal area. Articular surfaces were fairly well preserved. Once you reconstructed the articular surface.
Yes, sir.
So I think whatever appeared to be a ghastly X-ray earlier.
Yes, sir.
Was when a CT scan, once you see,
yes, sir,
it is not as ghastly because the articular surface was not crushed or it was not lost.
Yes,
articular surface was very well preserved. Once you reconstructed the posterior medial part,
yes, sir,
the whole thing became one piece,
yes,
on
sir,
which it was very easy for you to really fix it up.
Yes,
well fixed up, no question about it.
Yes, sir.
But I feel the severity is mainly in the X-ray. Once you see the CT, the articular surface, once it is good, I think then it becomes a straightforward, simple surgery.
The main problem was the lateral fragment, which was comminuted. The most important is the posterolateral fragment, which was completely subluxated from posterior side. So that need to be addressed properly.
But that with your skill, that's not the difficult issue.
I think
this was the only difficulty is that
I think the contentment was good. So once the contentment is good, everything goes well.
Yes, sir. So this is sort of fracture specific fixation. So all these fractures are totally different anatomy. Lateral is subluxated, lateral, posterolateral is subluxated. On the anterolateral side, there was a coronal slit, lateral meniscus was entrapped. And then again on the medial side also, there was 2 fractures, anteromedial and posteromedial. So this is a sort of fragment specific fixation, which helps in early mobilization of the patient and stability from day 1.
If you remember, we asked Dr. Tornado, he is not fixing posterolateral fragment.
That's right. That's right.
So so what was happening previously when we were not knowing about the posterior fixation? Tanna sir can answer about the
we never knew such a thing existed till the time the CT scans were seen and we started seeing all those fragments. I feel that probably posterolateral, I remember in one of the TraumaCon, somebody had asked me that question before all these approaches and other things came into picture. I said posterolateral, all I do is that when I open up anterior medially, anterior laterally, I try to get it some hook or something and try to get the posterior segment nearer, and that's all what we did. So nowadays when we are doing all these things, surgery or posteriorly, still the articular surface is not necessarily in a crushed bone like this, is not fully restored. And medially is very well restored, posterior laterally is not restored. And still, we hardly ever have an issue. So I think it's quite surprising whether Tornetta, what he believes, is probably to be rethink that when we go down for all those minor, small crashes on the posterior lateral, whether it needs something to be done.
So there are some articles also coming that if there is just a crack on the posterolateral part, I mean, we can conserve that also, or you can fix from anteroposterior screw can be put when we are putting a raft plate or variable angle plate. Through that we can fix it.
That's true. That's
yes,
true.
yes.
So Abhijit, Dr. Purohit wanted to present a case.
Yeah.
Thank you,
So
sir.
that is, so I think we'll be closing now. No?
So with the permission of the moderators and also the secretary of the web zone, we will close down on the Kale discussion. And may I ask Dr. Naveen Thakkar sir to give a vote of thanks?
Dr. Karna is there, no? He's a joint
Yes,
secretary,
sir,
and
sir
he
has
was going
probably,
to give. He has
yeah,
joined or
sir
not?
has probably locked out.
No, I'm here. I'm here.
Dr. Karne.
Sir, I'm Dr. Paras.
Dr. Paras, you want to present? Please present. Please
Sir.
present. Please.
Yeah, it's 2-minute case only.
I think we should allow the young orthopedic surgeon to present.
Hello, should I present my?
Yeah.
case,
You
sir?
can present. We can present.
Okay.
We'll listen your view. Yeah, your case.
Okay. Sir, I'll be presenting on a complex supracondylar fracture with bicondylar Hoffa's fracture. Can you see my screen, sir?
No, still it is showing sharing
Hello?
it. Still the pictures have not
Share,
come, sir.
share your PPT.
No, he's sharing. He has
Yeah,
started
I've
sharing.
already shared.
Yeah, now we can see.
Now we can see.
Okay. So it's a supracondylar fracture, young male.
Make it full.
Closed injury presented to us the day when.
Dr. Paras, make it full. Make it
Sir,
full.
it is full here.
But it has not come
full here.
It has not come full here, sir.
I'll just check.
Probably
I'll
there
just
is a
check
leg. There is a leg in the connection.
Yeah, you can go ahead. We can see on this also.
Yeah, you can go ahead.
Okay.
Can you
Sir,
able to change
Kale,
this?
25 years.
Can you change the
Right.
slide? Slide is not changing here.
Yeah. Sir, presented to us with a supracondylar fracture. He was previously operated for a medial tibial condyle. It was without any issues. He present.
You have again unsaid, please. You can share it.
Hello.
Sir, we have lost him. Yeah, he has joined back. Dr. Paras Motwani, can you start sharing your screen?
Please share.
चलो काकी साथे करो हाँ वीडियो कॉल
Yeah, we can see.
Where the sound is coming from? Govind bhai. Yes, Dr. Paras, you can go ahead. Hello, Dr. Paras.
Dr. Paras Motwani, we can't hear you.
Because
but
you're,
we can
you're muted. Please unmute yourself. First, unmute yourself, please. Unmute yourself, Dr. Paras, please. Hello, Dr. Paras.
Yes, sir.
Yes. Now
Audible?
Your
Am I audible,
connection-
sir?
You are audible now. You are audible.
Okay. Sir, can you see my screen?
Yes, we are able to see the CT scan slide.
Yeah. So this was a male patient with a closed injury with bicondylar Hoffa's fracture, with a fracture line extending up to the trochlear part.
And
With an
here tibia was fixed already previously.
Yeah, tibia was fixed without any issues 8 years back. And you can see the lateral patellar facet as an undisplaced fracture also.
Okay.
So what we did was.
Can you go for the next slide? Click
Yes,
once,
sir.
click once, and then go
Okay.
ahead. Then it will move if it is stayed there. Is it not moving? Is it moving or not moving? Can you give me a?
It was a nice.
If you allow me,
Approve.
Yeah, I am trying to click, but it's not working. It is hanged almost. Yours is hanged, I think. Your computer is hanged.
Now it is getting changed.
Okay. Fantastic.
So you can see the extent of fracture posteriorly, medially, laterally, with a chondral piece on the lateral femoral condyle also.
Okay.
So it's a midline TKR approach. Instead of taking two separate lateral approaches, we took a midline approach. Sir, can you please change the slide?
You can also do it.
Okay.
No issue.
Okay. So in the sagittal plane, you can see that it's Hoffa's fracture bilaterally. So on opening, we did it with a TKR approach. The patella is on the lateral side. You can see that the fracture line is extending here in the supracondylar area.
Right.
And in this, while flexing, the both condyles were separate. And in undisplaced crack, the fracture of the lateral facet of the patella. So we reduce the fracture first medially with help of K wires, laterally with the help of K wires. We put a posteromedial tibial plate on the medial side and two 4 mm CC screws to hold the medial Hoffa's fragment. And same was done on the lateral side with with a lease plate and a 2 CC screws on the lateral side. And a lost K wire was used to fit the chondral piece. So at the end of the fixation, this we were able to achieve. And this was the movement we were able to achieve after fixation of the fracture.
Good. So you supported with the buttress plate also.
Yeah, these were the pre-ops on the upper X-rays, and the lower X-rays are the post-op images.
Good.
Thank you.
Very good. Was there any issue with the MCL attachment while putting the plate?
No, sir. We just through the TKR approach, we were able to slide. We just put buttress the plate on the MCL femoral origin itself.
Okay.
And it was a very low. You can see that the fracture line was the lateral condyle was almost say 12 mm, both sides. So
very good.
So orthogonal fixation was with the help of 2 screws first and then a buttressing plate. So, and a patient has fantastic movements. He is from Rajasthan and he is making sweets, so he is not able to come to Rajkot. This case was operated by me 8 months back.
Fantastic. Anybody has any question for this case? Anybody has any question? Chandak sir? Hello?
So probably so no question.
Okay.
Yeah, but
so Kamlesh bhai, do you want to present or we can make it a closer? Okay, thank you Kamlesh bhai. So thank you all the faculty. In place of Dr. Karne, I am just giving a thanksgiving to all the faculty and
Naveen
all the
bhai.
contributors. Yes sir.
Okay.
Hello,
Naveen bhai.
Yeah, please.
2 minutes, my case. Hoffa's fracture, 9 years old.
Yeah. Go ahead.
Yeah.
2 minutes, but make it fast, please, sir.
Next slide.
Go.
Please.
Make it full.
Uday, slide show from the beginning. Next slide. This was 41-year-old male vehicular accident in 1997, treated by aspiration of hemarthrosis. Pain right knee with clicking, no limp, no instability, no difficulty in squatting or sitting, cross-legged, full range of movements, no instability, clicking on the lateral aspect of the knee. Something pops out at the lateral aspect. Next. This was the X-ray at the end of 9 years. I have one video to show. Video batavjo Uday. This is the CT scan which show typical non-union. So video. Uday.
He answered it.
Video is very interesting.
Okay, fine. Show us, no issue.
We have taken the dynamic picture of the IITV also. So video, normal video first, Uday.
Okay.
First, second, third. Only 1 minute video.
No issue. It's not running.
Uday.
Open it, please. It's not opening. Right click and then open.
Right click kar Uday.
And whatever software it is working, please.
ओपन कर भाई राइट क्लिक કરીને करो फटाफट
That computer is not working fast. Now it is working.
Yeah. Now. Actually, I am at Rajasthan and this video is displayed from my hospital.
Yeah. This is post-op, I think.
No, we have not done anything. Patient came 9 years to me. He had no complaint and no surgery is being done. So what I was asking, what is the natural course of the fracture of the Hoffas if it is not treated and going for non-union? So this is the natural course at the end of the 9 years. Very, you can see something popping out at the knee joint on the movement.
But it's stable.
Yeah, very stable. Patient is doing all activities, sitting cross-legged, squatting, getting upstairs, getting downstairs, even running also, something coming out at the knee lateral aspect.
Right.
You can see it.
Right. Fantastic.
We have also taken dynamic CM picture also of the lateral view to see the fragment, how it is moving.
Okay.
Triju.
Third IITV, please IITV.
Third IITV वालों भाई उदय. Third.
1003533.
See some.
Okay. Next.
Something is popping out at that level. Yes, this is the dynamic view.
Yes, that is moving. That fragment is moving. Yeah.
So it has not united, completely non-union on one side, and still patient has no complaint. So sometimes
there is a fibrous hinge.
Fibrous hinge. It has occurred with good stability, no problem with the patient.
Fantastic.
Still one more case I have sent you. Lower femur.
We will discuss later on. I think.
Okay. Very badly communicated femur.
Yes.
And still patient no problem. Thank you all.
Thank you for taking a pain. Being in the Rajasthan, you're getting connected to hospital and getting the case.
Thank you for giving me the opportunity.
No. You deserve
Thank you very much.
So I thank you to all, and we are thankful to the team of Ortho TV. Kamlesh bhai, Ortho TV team, you can stop streaming now. Who is there? Rajesh bhai?
Yes, sir. We will do that.
Thank you, sir.
बस अब बंद कर दे.
Can you stop streaming and recording both?
Yes, sir. I'm just making an attempt because you and I both are co-hosts right now.
I am doing.
We are co-hosts, so we can do that.
Don't pressurize, no, not right. माथा पर ऊपर नहीं करा.
I'm making the, I am leaving the meeting we are closing. That is better, I think. That will
Yeah, I
close
think.
everything. That will close everything.